Yeah, likely.
A very good evening to all of you, and welcome to this session on newer drugs in glaucoma and update. We have with us esteemed faculty and our respected chairperson, Dr. Satyan sir. For moderators, we have Dr. Amit Porwal sir, Dr. Prasanna sir, and our esteemed panelists, Dr. Brian Ang sir from Singapore, Dr. Deventoli sir, and Dr. Manish Shah. And we have an esteemed line of speakers on this topic. And we are looking forward to all of the wonderful discussions that are going to be in this learning session. I now invite Dr. Satyan sir for his opening remarks on the topic.
Very good evening to each and every one of you, and a warm welcome to all the audience. Such a great evening, and I'm really thankful, one, for the AI voice, and to all our international speakers. A wonderful international speakers we have today, and I really want to specifically mention that within a very quick time period that they all have accepted without any hesitation to our request. Thank you so much, each one of you, for accepting our invitation and to be a part of our program today. And it is going to be such a great event. And I'm sure that all our people, whoever is learning from this webinar, will take it forward in their clinical practice. That is what the entire thing is all about, because our day-to-day practice, whether this all can be used so that it really benefits our population. So thanks again to all our speakers, and as well as to AIYs, and then probably we'll go with our program. Thank you, Nitika, and each and everyone.
Thank you, sir. I would like to invite Dr. Manoj Mathur, sir, our esteemed chairperson, for his opening remarks, please.
It's my pleasure to welcome you all for this glaucoma session on newer drugs in glaucoma. It was way back in the 70s that the drug Timolol was launched, and that was probably the only drug complementing pilocarpine that was used earlier. Since those days till today, we have a plethora of anti-glaucoma medications with diverse mechanisms of actions, and now currently preservative-free drugs and the fixed combination, the double, triple combinations, and so on. So we have a plethora of combinations available to us. So I am sure that this session is going to be of immense value to the audience, and they will be knowing in detail about which medicine to use, what combinations of medicines to use, what is the maximum medication that can be used in the present day context. And I thank all the speakers, international speakers, for readily accepting AIOS invitation and being present here. I am sure this is going to be a very enlightening session. Wish you all the very best.
Thank you very much, sir. I would like to introduce the session coordinators for today, myself, Dr. Nitika Berry, and Dr. Tichai Diodam Tara. And without further ado, I would like to also inform that Dr. Amit Porwal sir and Dr. Prasanna sir could not join us today. And on their behalf, I would be doing the moderation. So I would like to share my screen and do the honors of faculty introduction, please. Dr. Techi, could you please unshare your screen, please? Is my screen visible?
Yes, Nitika.
Thank you. So it is with great pleasure that I do the faculty introduction. We have our chairpersons, Dr. Manoj Chandra Mathur, sir. He's an esteemed glaucoma and cataract specialist and an academic leader and our ordinary treasurer of AIOS. He has won multiple awards and is our guiding lamp for the AIOS. We have with her Dr. Satyan Parstati, sir, and he has more than multiple years of experience in ophthalmology and is currently the president of Glaucoma Society of India. And we have great pleasure in learning from him multiple surgical, clinical, and academic skills as well. I would like to introduce our moderators for the sessions with Dr. Amit Porwal, sir. He's Head and Department of Glaucoma at Chirotram Netralaya, Indore. He's an academic leader and internationally recognized glaucoma specialist with multiple invited lectures and scientific presentations to his name. I would like to further introduce Dr. Prasanna Venkatesh Ramesh, sir. He's a moderator. He's editor-in-chief for the journal from the Tamil Nadu Ophthalmic Association, the joint secretary of the Young Ophthalmologist Society of India, a very dynamic personality and a recipient of multiple awards, as you can see on the screen. It's my great pleasure to introduce Dr. Brian Nang, sir, from Singapore, who's very kindly accepted our invitation. He's the adjunct assistant professor and deputy head of glaucoma services at the National Healthcare Group of Eye Institute at Singapore. He's a fellow of the Royal College of Ophthalmologists, internationally recognized MIGS experts with multiple publications. He's also had the best video in World Glaucoma Congress, and he's a clinical scientist and educator. We are very happy to have you with us, sir. I would like to introduce Dr. Deven Kohli, sir. He's a senior ophthalmologist with more than 30 plus experience in the field. He's a national leader in glaucoma care and presently the honorary treasurer for the Glaucoma Society of India. He has a patient-centric eye approach towards his patients, and he's a very encouraging person. I welcome Dr. Manish Shah, sir. He is the founder and foresight of Eye Center and Glaucoma Clinic and a senior consultant with more than 22 years of expertise in the field of glaucoma and anterior segment. He's presently our honorary general secretary for the Glaucoma Society of India. He's a dedicated educator and a mentor. We welcome you, sir. I would now like to proceed by introducing our esteemed panel of faculty speakers from various countries. Dr. Hong Ki NG, we welcome you, sir. He's the head in Department of Ophthalmology at the Hospital Raja Parmeswari Bedam. Please forgive me if my pronunciation is not correct, sir. It's from Malaysia. We welcome you, sir. He's a trained glaucoma fellowship specialist with expertise in glaucoma, cataract, and complex anterior segment surgery. He's an academic leader and researcher. Thank you for accepting our invitation, sir. I would like to introduce Dr. Shivam Gupta. Sir has very kindly agreed to be a part of the symposium at the last moment. Thank you, especially to you, sir. He's a glaucoma specialist, researcher, and innovator. He has multiple patents to his name with more than 25 plus publications. He's an award-winning academic presenter, a young achiever, and a part of multiple innovation projects with multiple patents to his name. We welcome you, sir. Dr. Shams M.T. Noman. I'm very pleased to introduce, sir. He's a senior glaucoma specialist with extensive expertise in medical, laser, and surgical glaucoma management, including congenital glaucoma and glaucoma drainage devices and MIGS. He's an internationally recognized academic and educational leader. He's invited speakers at multiple platforms and accomplished researcher and award recipients with multiple publications and awards to his name. We welcome you, sir, and thank you for accepting our invitation. I would like to introduce Dr. Pushpa Raman, who is a glaucoma and a cataract specialist with advanced training from National University of Ireland, University of Malaya, and the prestigious Glaucoma Fellowship at Sydney Eye Hospital, Australia. She's an academic leader and a researcher with expertise in advanced glaucoma surgeries and MIGS, including all the MIGS I can see here. We welcome you, ma'am. Thank you for accepting our invitation. I would like to introduce Dr. Andy Tensinana Devi Indra. We welcome you, ma'am. She's the Director of Medical Services in RSUP. Dr. Tejuddin Chalat Bakasar. Please forgive my pronunciation if they go wrong, ma'am. She's the consultant and lecturer in glaucoma subdivision in the Department of Ophthalmology at the Hasanuddin University. She's a glaucoma and cataract specialist with an expertise in laser procedure, trabeculectomy, and multiple procedures of the anterior segment. She's an active researcher and a professional leader. Thank you for accepting our invitation, madam. Thank you so much. With this, I would like to stop sharing my screen, and I would like to invite our first speaker, Dr. Hong Ki NG, who will be speaking on the topic, Focus on Brinzolamide, Modern Approach to Carbonic Anhydrase Inhibitors. inhibition, sorry. Thank you. Over to you, sir.
Thank you very much, Dr. Deepika, for the kind introductions. Can you see my screen?
Yes, sir. We can see your screen.
Thank you very much. So thank you once again, and good evening to all the senior consultants, panelists, and everyone's on for today. My name is Hongki. I'm from Ipoh, Malaysia, and thank you once again to the AIOS and the IOC Organizing Committee for the kind invitation. And today I'm going to share on the focus on brinzolamide, the modern approaches in the carbon anhydrase inhibitions. No financial disclosure in regards to these presentations. And this is the outline of my talk for this evening, basically focusing on the brinzolamide versus dorzolamide in terms of efficacy, dosing, tolerability, adverse event as escalation of treatment options. So as we all know that glaucoma is a leading cause of irreversible blindness worldwide and is projected to affect more than 100 million people globally by the year 2040. The goal of treatment mainly focuses on how to preserve the maximum functional visions throughout a patient's lifetime without sacrificing quality of life and at a sustainable cost by decreasing the IOP. So according to the Asia Pacific Glaucoma guidelines, we usually start with the first choice, monotherapy, which is commonly the prostaglandin analog or the PGAs. Then we need to monitor for tolerability and whether the target IOP is achieved. If it's not, we can either add on the second agents, add to become a fixed combi, or to switch monotherapy. The common second line is beta blocker. However, in certain clinical challenges whereby patients is contraindicated to this beta blocker, like for example, asthmatic patients have arrhythmia, then the option of second line would be either CAI or the alpha agonist. So the mechanism of action for this CAI is to inhibit the carbon anhydrase enzymes in the ciliary processes to reduce the formation of the bicarb and reduce ion transport and eventually lead to a decrease in the aqueous humor productions. There are currently two main groups of CAI widely available, which is dorzolamide 2% and also the later one, the brinzolamide 1%. So how does the brinzolamide is better than dorzolamide in the modern glaucoma therapy? Specifically, in the brinzolamide, we're talking about the adsorb, whereby the main differences actually lie on the physical state and the solubility of it. Brinzolamide is in a suspension state, it's hydrophobic, and is free to formulate at a neutral pH, which means that it translates into a better ocular comfort and less side effect as well as enhancing compliance. Whereas on the other hand, dorzolamide is a solution formulated at a more acidic pH of 5.6, which can cause ocular surface irritation such as stinging and burning sensation after installations. So firstly, we focus on efficacy. Can brinzolamide be used as a second agent adjunctive to PGA? Or is it as good as by adding timolol as the current practice? These 4-week studies compared the brinzolamide, timolol, and brimonidine as adjunctive therapy as a second agent onto existing PGA. At week 4, brinzolamide had the greatest reduction of IOP at 22.7%, which is way higher than brimonidine at the 13.4%. And furthermore, the brinzolamide have shown that IOP lowering effects were numerically greater than the timolol itself. How about dosing itself? Comparing efficacy of brinzolamide twice a day versus 3 times a day show that there's no clinically significant differences when set a threshold of 1 mm mercury. Similarly, if we compare with the brinzolamide twice a day, compared with the dorzolamide 3 times a day, where the difference is also less than 1 mm mercury, which means that the brinzolamide twice a day is as efficacious as the dorzolamide 3 times a day dosing, which translated means that simplified dosing for patient is easier for patient, less exposure to BAK, as better tolerance, as well as better compliance on the patient side. This possible explanation is because the brinzolamide is a suspension state. It's more viscous, it's more difficult to be washed away, and hence it tends to form like a microparticles in the tear film that provide like a sustained release effects in the long run. Looking into tolerability and adherence, it is a known fact that the ocular discomfort is a common tolerability concerns with the CAIs. This comparative safety data of 4 clinical studies have shown that the brinzolamide-containing regimes demonstrated consistently a favorable safety profile with significantly less ocular irritation than the dorzolamide-containing regime itself. But if we look into the details of the different adverse events of the CAI, brinzolamide has much reduced ocular discomfort compared to the dorzolamide itself, which is 3% versus 16%. And interestingly, also looking at the patient-reported tolerability ratings, the brinzolamide group, which is in this study, fixed combination of brinzolamide and timolol, have shown a more favorable tolerability as shown in the blue color bar, which is a very good and good tolerability versus the dorzolamide timolol fixed combi dose, which is the lower one, up to 37%. The reason for the tolerability mostly due to the formulation cells, whereby for the dorzolamide it's a more acidic pH, and this leads to ocular surface irritations. The great evidence summary and clinical conclusion is summarized that the brinzolamide timolol fixed combination has a modestly greater morning IOP reduction and less irritation. However, it's also associated with a significantly more blurred vision in compared to the dorzolamide group as well. And it's recommended the choice it depends on the individual patient's tolerability profile and it requires a long-term data to confirm its comparative outcome. But if we look at these profile metrics between these two CAIs, is that brinzolamide may have a severe VA drop, which acuity drop at the beginning of putting the drop, which is more than the dorzolamide. However, both usually recover to the clinical before dropping the drops about 3 minutes, according to the Ishibashi study at all. And the primary source of the cause why it's a blurring in brinzolamide because of the suspension preparation, because of opaque layer, whereas on the dorzolamide group is because of the irritation lead to the reflex tearing and cause a blurring of vision. But you look at it further deeper, the brinzolamide just show a low incidence of moderate to severe irritation, which means patient is more comfortable and will thank you for giving them a more tolerable eye drop compared to dorzolamide, which is pretty high incidence at 71% with moderate and severe irritation. So if your patient is happier, we as a clinician is also happier because patient has a better compliance, which translated into a better glaucoma control. The patient may be seeing it with a prettier eye and less complaint during your OPD visits. And the final point is focused on opportunity to escalate treatment by adding another agent into assisting of the brinzolamide or CAI groups. For example, we do have the fixed combination of brinzolamide and timolol, as well as a fixed dose combination of brinzolamide and brimonidine. So if the patient is already on a non-fixed dose, for example, on PGA plus with either brinzolamide or dorzolamide, and require a further additional class of medications, by swapping them into a fixed dose of the brinzolamide timolol, we give you the additional 21 to 22% further IOP reductions. And it's surprising to find out that if patient is already on PGA and a fixed dose of dorzolamide timolol group, by swapping it into a fixed dose of the brinzolamide timolol group, it will give you some additional of 10.4% reduction IOP. So in conclusion, brinzolamide family has a strong efficacy and potential therapeutic effect, which is not inferior to dorzolamide group. And the good thing is it's milder to the eye with a physiologic pH advantage, which translates to strong tolerability and better adherence and compliance. We can also reduce the dosing to BD to reduce the VAK exposure and enhance the tolerability. And lastly, we can play around to step up and as well treatment retention depends on the patient clinical conditions. So before I end, I would like to invite all the audience to join us in Malaysia for the Malaysian Ophthalmology Scientific Congress 2026 in Kuala Lumpur from 10 to 12 July 2026, as well as the Malaysian Annual Glaucoma Symposium, which will be next month in Kuantan, and the ASEAN Ophthalmology Scientific Congress in 2027.
Am I going to the room? Teacher,
So with
I'm
that,
going to the
thank you, Navayat, and terima kasih.
I can't hear person.
Thank you, Dr. Honky. Thank you for that wonderful talk. I would now like to invite Dr. Satyan sir for his comments, please, and to initiate the discussion.
Yeah. Thank you so much for this wonderful presentation. Again, both the drugs, both the carbonic anhydrase inhibitors, the dorzolamide as well as the brinzolamide has been there for a very long time. But in general, if you really look at the dorzolamide acceptance, especially in India, is much more, possibly because of the early introduction of the dorzolamide than the brinzolamide. You already mentioned that the brinzolamide as a suspension, it has more blur. And though we know the dorzolamide has a higher acidic pH, so that is the reason, one of the reasons why the people have more problem in the taste, especially the bitter taste. in comparison to the brinzolamide. So having said that, is it a preferred molecule for you that the brinzolamide is a better molecule that you choose to use to begin with in comparison to the dalzalamide? The the theoretical part to an extent is some of the published article shows that the dalzalamide slightly has a edge in the IOP as well as on the blood flow augmentation. Do you go with that, or do you do something to say that okay, in these cases I would like to go with the dalzalamide, and in these patients I would like to go with the brinzolamide? Is that anything that you have, like a kind of a marker that which one you choose?
Thank you very much, doctors, for the comments. So in Malaysia, because currently I'm practicing in the public health systems, so dorzolamide is considered as a standard in terms of CAI, where brinzolamide is more expensive, so it's only on a case-to-case basis. So in my daily routine, I still use dorzolamide as the first line, require CAI. But for those patients who have kind of there's a face problem or complaint of some stinging, irritation, then sometimes I do offer ask them whether they prefer to swab it into a brinzolamide is one of the options as well.
All right. So basically, when the patient has any issues associated with the dalzalamide combo, then you switch over to brinzolamide combo. Okay. So that is going to be the main thing for you. Okay. So is there any sorry?
The main thing, like as Satyan said about the vasoperfusion component, dorzolamide, it has shown there are established studies of vasoperfusion, qualitative studies, no doubt. Still, the quantification process is yet to be achieved. So, as far as vasoperfusion is concerned, dorzolamide does have an edge over brinzolamide. That's what I say.
Thank you, sir. Quick comment from Dr. Brian Ang, sir, and Dr. Deven Tubi, sir. Would you like to add anything, or shall we move to the next topic? Dr. Brian, sir, Dr. Deven, sir.
Yeah. Thanks very much, Onki. I think that was a great talk and a great summary as well. I have some questions perhaps for the panelists as well to get some of your opinions. Just looking at contraindications or concerns, particularly in two main areas, in corneal disease, underlying corneal disease, as well as in patients with renal issues. Would that be a concern for some of you in your practice? I'd like to get your experience on that.
That's a great question, Brian. But if you really look at even including the oral acetazolamide, if you really go through the entire process, we really don't have to kind of completely stop unless you see that the creatinine levels and also how much is the complete renal compromise. We got to be in touch with the nephrologist to understand whether that is really a compromised kidney that we should not be using. So especially for dalzalamide and brinzolamide as a topical solution, I don't see too much of a contraindication if the patient has, even if the patient has renal compromise. But we need to be careful about their level of damage and also the creatinine levels. That is one indicator. There's a good guidelines given on the blood urea. How much is the blood urea that we should be avoiding the dalzalamide or the CI?
And if I may add, also look at the acidosis levels. So just want the patient for the acidosis markers, and if that is there, then they should seek opinion. Regarding the endothelium part or the corneal part, I think between, we talk to a lot of cornea colleagues here, and if they have to use dorzolamide and brinzolamide and compromised endothelium, they generally would go brinzolamide first and leave dorzolamide absolutely the last, maybe before surgery.
Thank you, sir.
In general, if there is no other go that we need to use, sometimes we do use it, but majority of the time we try to avoid as much as possible in compromised corneas.
Thanks so much for those inputs. In my own practice, I use it on the basis that if I really need to use it, then I perhaps would use it in some of these patients. The other thing I would add also is Sometimes if I need to use it, I will advise punctal occlusion, and that might help to some extent as well to reduce systemic absorption. That's the only thing I'll add to the excellent comments. Thank you so much.
Yeah.
So I
Thank
think
you for the
regarding
wonderful comments.
regarding the punctal occlusion, I think we should advise it for all drugs. I think all have some issues, so that is something we do. Thanks a lot. I think Nikita, you must move on for the interest of time.
Yes, sir. Yes,
Can
sir.
I ask one question?
Yes,
Yeah,
madam.
please.
We'll have to be a little quick,
I'm
please,
sorry.
so that
Yeah,
we can.
quick,
Yes.
just very quick.
Yeah.
I have a patient that using brimzolamide for years, and then after years, the conjunctiva become hyperema. So I stopped the drops and I switched to the other eye drops, and then after that, the IOP is not controlled. So what do you opinion about that? If I get the patient that like that, should I another eye drop is not suitable, so the IOP, do you think how many I have to change, or the patient still want to use that drop because it happened after years, so I have to stop, and when I can use that eye drop back, the bramzolamide? Thank you.
So basically, the moment you start having a adverse event of a drug, one thing is for sure, it is probably, even if you want to continue, it is going to be only for a short time. And we know the glaucoma is not a short-term disease. So somehow we have to see that how soon we can change the drug to either you stop the drug, change over to the another drug, or you look for the other modalities of treatment like laser possibilities, and also the surgical options one might have to really look into, because it's not going to be forever, because the patient has to use it for lifetime in case we have to give. So we need to see if the patient has an adverse event and it is very notably there significant it is, I think we'll have to look at change over to something else. Yeah.
Thank you, sir. In the interest of time, I would like to now invite the next speaker, Dr. Shivam Gupta, sir, and his topic of presentation is the next percent in glaucoma medication. Sir, please, if you could share your slide. Thank you.
Hope my slides are visible.
Yes,
absolutely, sir.
So good evening, all. Thank you, scientific committee. Thank you, Satyan, sir. And it's a great honor to be just amongst all the stalwarts of the glaucoma, and it's a great honor to be here. So I'll just start with my presentation on starting with this video. This is very disheartening to see in glaucoma OPDs, the patient coming with such eye drop with fungus going on in the tube. So it breaks the heart. And then we come out to that still in 2026, the challenges still are there. A lot of challenges are there for medical management. We have to consider that glaucoma is a lifelong disease, and there's a poor patient compliance and adherence is there. Also, which we are discussing recently, there is ocular surface toxicity because of the preservatives and all. And the cost accessibility is also an issue. And also, there is progression despite apparently normal controlled intraocular pressure. So, like sir was discussing, Dr. Mathur sir was discussing, we have come a long way from cholinergic agonists to osmotic agents to oral carbonic anhydrate inhibitors to beta adrenergics, and recently we are working on ROCK inhibitors. So, what are the unmet therapeutic needs which can be addressed now? Are the need for neuroprotective agents, a sustained release drugs, newer drug delivery systems, and need for preservative-free drops. So these 2 points will be covered in the subsequent talk. So I'll start with the newer drug delivery systems. So it's nothing which is not new. In 1975, already there was a Pilo 20 which was used, which was later discontinued because of tolerability. Then bimatropras came with something new, which is called Bimring, which is continuously elutes bimatropras for a period of 6 months. The rate of drug elution is 30 microgram per day for the day insertion to roughly 6 mcg till 6 months. And it has completed the phase 3 trials for now. Similarly, bimatropras can be used for intracameral insertion also. It is a sustained release biodegradable implant that uses Novardo drug delivery system for intracameral use. A rod-shaped implant is administered into the anterior chamber using a 28-gauge single-use profiled applicator, and the Artemis 1 trial has shown both the 10 and 15 mcg non-inferior to Timolol. Similarly, we have iDose now, in which which has a formulation of travoplast, which can last up to 12 months. The only problem is that we have to take the patient into OT, and it lasts for only 12 months. So then we have to again remove it. And here you can see that it has 3 parts: one for the trabecular meshwork insertion, one this titanium capsule, and there is a pre-filled area in which the drug is eluted. Similarly, we have ENB15, which has the implant consists of biodegradable drug delivery system, releases travoplast for up to 6 to 12 months. Again, we are having the same problem that these drug delivery systems only work for a short duration. So similarly, we have something which can be used as a punctum plug. The punctum plugs have been long been used for treating dry eyes, and these plugs have been recently used for glaucoma drugs also. So here we are using this travoplast punctum plug, which elutes the drug from roughly 90 days. Similar to travoplast, we have OTX-TP, which has also travoplast, but it has a modification that it elutes drop for 10 months period. Similarly, we have Evolute, which is a mighty distribution in loaded with letonoprast, and it recently completed phase 2 trials so that 90% of the had a 12 weeks duration of action. Not only punctal plus, we have contact lens based drug delivery system in which silicon hydrogel contact lens are loaded with drug nanoparticles. These drugs diffuse into the tear film and increase the viability up to 50%. Similarly, along with cataract surgery, we have Spyglass or the IOL haptic based drug delivery system in which these haptics are loaded with the drugs, like in which also we are using bimatoprost. But again, the drawback to this is it can only for 3 years, and then again we have to add some other medication also. Similarly, there are many experimental things which are going on, like subconjunctival injection of dorzolamide loaded polymer microparticles, supraciliary injection of brimonidine latent microsphere, intravitreal injection of brimonidine or travoplast, bimatoprost latent nanospace having completed successful animal studies. So what are the newer agents which are already coming to the market and they are almost there? Some of them are like letonoprazole bunod, which has nitric oxide donating prostaglandin F2 alpha agonist, and which has two mechanisms of action, which increases by nitric oxide mediated conventional outflow, as well as FT receptor mediated US non-conventional outflow pathway is also increased. Similarly, we have prostanoid receptor agonist, which is omnidipag, which is recently introduced in Indian markets also. It decreases the IOP by increasing the conventional and uvascular outflow. So again, there are different studies, which are Voyager study, Constellation study, Apollo study, Lunar study, which have showed non-inferiority to letonoprast. So coming on to other drugs which are available are Septoplast, which has phase 2 and 3 clinical trials, which is a prodrug activating FP and EP3 receptors. Similarly, we have NCX470, which is again nitric oxide donating prostaglandin analog, which can be combined with bimatoprost also. Along, if we are talking about combination, recently introduced combination is a rocklatan, which is combination of nitatrosol with letonoprast. Coming on to another drug delivery system and which we can target are the nanoparticle range from 1 to 100 size. And these medications can be piggybacked on the various nanoparticles and which will help in bypassing the biological barriers. A drug called as catonylase has been recently studied, which has a letonoprast loaded nanoemulsification, and it uses a Novazorb technology developed by them, which can help to bypass the biological barrier and increase the ocular surface penetration and drug effect. Similarly, we have adenosine receptor agonists, which are coming in the market, which are nucleoside that activates G protein linked to adenosine receptor A1, A2A, A2B, and A23. It increases the conventional outflow facility by shrinkage of the cell volume and remodeling the extracellular matrix in human trabecular meshwork. So now we have drops which are changing the trabecular meshwork in toto, which increase the outflow pathway by increasing the matrix metalloproteinase, which removes the collagen type 4. So again, we have another pathway called small interference RNA, like bamosiran is a siRNA developed to specifically silence the beta-2 adrenergic receptor in the ciliary body, thereby reducing the aqueous humor outflow. Again, if we are going about genetics, we can also think about the stem cell therapy, which has great attention as a potential source of cell replacement in disease that lead to blindness, such as glaucoma. So coming on to some studies which are going on stem cells are the intravitreal mesenchymal cell transplantation in advanced glaucoma, stem cell ophthalmology study in MSC delivery via subtenon retrievable IV route, the effectiveness and safety of adipose-derived regenerative cells for treatment of glaucomatous and neurogenic study are being under clinical trials. So again, it's not just what everything, one size doesn't fit at all. And now we have to move towards a personalized glaucoma management. Meaning to what? We need to do polygenic risk scoring, and we have to, genomics may hold the key to unlocking the future biological insights and enabling precision medicine in which glaucoma is tolerated to the individual patient based on the unique profile. So in which what we can do is biomarker guided therapy, and we have to start thinking about pharmacogenomics, and we have to start about what trabecular meshwork and why someone is having more fast progressor, why someone is a slow progressor, and then we have to tailor made to that particular patient. Not only that, we have to till these things are developing, we have some innovations to increase the drug compliance. So in this, we have the detailed step, like this PeerMax had developed a drop smart method in which they use how to apply it. Along with that, we can check whether the patient is compliance can be checked by this method in which there is a biosensor to check whether the drops have been used properly or not. Another one is a cloud-based AI support method in which the blood drop is being checked. Not only that, we all our glaucoma patients are quite old and they are not able to sometimes instill the drop. So there is a technology called smart drop which checks whether the patient is using the drop properly, as well as it helps in the tactile guiding of the drop to the directly it goes inside the eye. Along with that, what's the easy way which we are doing in Arvind Eye Hospital? We give some patients all these charts in which patient ticks on what all drops he has used for the month. So what will glaucoma medical therapy look like in 2036? That's a big question. And I believe it should be a drop-free glaucoma care. A sustained disease implant should take over. The personalized therapy should be given a more push. And there should be AI-guided treatment and a more talk about a neuroregeneration. So it falls on, and yes, I was a very young person speaking amongst all the senior speakers, and a great honor. But this problem and this like a goal for us young glaucoma warriors to think about it. And yes, much has been done and much remains to be done. Thank you.
Thank you, sir, for beautifully summarizing such a vast topic in a few minutes of 8 minutes. I would now like to invite our chairpersons for their comments and the panelists, please. Thank you.
Yeah. Thanks, Shivam, for a quick preparation and then giving the overall view of the next generation of how the glaucoma medications are going to be. And we are all kind of excited for a reason. And I'll just give you the background why it is important for us. If you really look at the Indian typical patient profiles, at the end of the first year, we lose about 50% of them, close to 50% of them coming back for follow-up. And interestingly, at the end of the first year, close to about 45% of the people will require additional medication. So there are two interesting things which I have told you now. So having said that, when the patient is going to be not coming back for follow-up, some may be still continuing to use the drops, but majority of them, they don't use the drops. So if we don't have any other way how we can, reduce the intraocular pressure without the medication, then we'll look at all other modalities. Either we go for the laser procedures like SLT in POAG or some kind of open angle glaucomas, or you go for the MIGS or trabeculectomy as a surgical option. Now, when we have the options of looking at all these kind of the implants, especially like a Skylens, which we also had some idea on, and it has come for some kind of a study for us as well. So these are the other ways how we can still use the drug to reduce the intraocular pressure without much of the compliance as a major issue. So this will really help us. So we are also kind of developing a newer implant which is completed its 5 months phase. So we are just looking at a minimum drug delivery of about 1 year from the implant, where we can load 5 different classes of drugs in the single implant, which is going to be the subconjunctival implant. As of now, we are not going to probably reveal any of the details until we have all the outcomes. So this is how the things are.
Nitika, you can ask Brian to comment, please.
Yeah,
Yes.
I'm still there. Okay.
Yes, sir. You're
Okay,
audible
I
and
thought I
visible.
lost my.
No, you never lost Dr. Satyam. We are very much.
Sorry, I'm sorry. I thought I just lost the line. So this is how we should really look into how the implants can really help our patients, compliance as well as to control the disease. But this is the new future going to be. Over to you, Nitika.
Dr. Brian, sir, would you like to add any comment? In the interest of time, we'll take Brian, sir, and then move forward for the next session, please. Next speaker, please.
Thank you. Very humble to that. Just very quick, 1 or 2 comments from me. I think one, obviously, that was a great talk with a great summary of all the new stuff that's emerging and coming on board. And what this does is it gives us options, and it gives us options for the future. But I think the challenge here is how 2 things: 1, cost and accessibility, and 2, how do we fit all this new available drugs and technology into our treatment algorithm? It's not as straightforward. We will need a lot of evidence, a lot of scientific evidence, real world evidence to fit into some form of consensus guidelines for us, so we understand how it fits into our current treatment algorithm. And I think that will be the next challenge for all of us. There's going to be a lot of things coming up, just like MIGS, for example, and I think the challenge will be for all of us to be able to understand them well enough and to use them adequate enough so that we know how it fits best for our patients. Those are just my 2 very short comments, and it was a very, very good talk. Thank you so much, Dr. Shiva.
Thank you, sir. So in the interest of time, we'll move on to the next speaker. So Dr. Sham MD Norman, I would like to please invite to please speak on the topic Beyond Pressure, the new era of anti-glaucoma medication. Over to you, please. Thank you.
Is it visible?
Yes, can you make it to slideshow? Perfect.
I have almost the same presentation like a previous presentation, because new era in the medical management of glaucoma, my topic. Though, so I will just add something with the previous presentation. And thank you for inviting me. This is Dr. Shams Noman. I'm the head of Glaucoma, Bangladesh Medical University. I don't have any financial disclosure. So what is the focus of new era of medical management of glaucoma? The first thing is the neuroprotection, sustained release delivery, what Dr. Shivam already discussed. Dose convenience is a factor. This is the because dosing is a great factor, and patients are very much choosy about the single or very little doses. And obviously, adverse effect is a great thing to continue the compliance. So Rho kinase inhibitor, we know this is the latest innovations, the natrosudil and riparsudil. It is the increasing the ability of the Slem's canal endothelial cells to form the pores, and relaxation of the smooth muscle fiber of the trabecular mesh that increase the outflow. And this is almost available in this subcontinent. The most important thing is relaxing muscle by inhibiting the myosin, increase the blood flow that causing the neuroprotection, and inhibition of the fibroblast. That is the most interesting thing that may decrease the trabeculectomy failure. This causes 30% reduction of intraocular pressure. And fasudil is a newer Rho kinase inhibitor that is some added advantage. Like it can be used in the advanced glaucoma, sustained effect, less hyperemia, and it has available in the ocular gel format, but it is an ongoing trial. Excuse me. Latanoprostene Bunod. This is available in our country. This is it has a nitric oxide donating prostaglandin alpha 2 analog. It has the extra nitric oxide, which has a vasodilator effect. For this, it has in the conventional pathway and also in the prostaglandin pathway. By both pathway can be this drug can work. And the special characteristics of this medication is reduce the diurnal variation, and the side effect is very transient. And sometimes the 40% reduction of intraocular pressure has been shown. And Dr. Shivam already told about the newer drug delivery system. Why? The patient who are non-compliant, missing doses and for the adverse effects. So I think that will be a new era for in the glaucoma medication. Bimatoprost implant Durista, the Novadu technology drug delivery system for the intracameral use. You can see, thanks Allergan for inventing such a. I don't have any financial interest. This is a Bimatoprost implant, first approval, and you can see the device. And another thing is Bimatoprost ocular ring. You can see there is a ocular ring at the level of the fornix, and this can gradually just secreting the Bimatoprost. Travoprost punctal plug, OTX-TP, Ocular Therapeutics, they have introduced it. It is a sustained delivery system which works up to 90 days. Then it have to be changed. The most important thing is if you implant the punctal plug, this is the hygiene is very much important, because for this the punctum can be occluded. And feasibility study of sustained release travoprost punctal plug for intraocular pressure reduction in an ASIAL population. The study shows it works good. And you can see travoprost punctal plug here. Usually it implant into the lower punctum. So nanotechnology, a novel route of drug delivery that is first evolving. Nanoparticle is 1 to 100 nanometer in size, have the ability to bypass the biological barrier. You know, if we can bypass the biological barriers, what is the most important site of glaucoma pathology? So subsequent conjunctival injection of dorzolamide-loaded polymer microparticles and supraciliary injection of brimonidine-laden microspheres and intravitreal injection of brimonidine, travoprost, and bimatoprost-laden nanosponges have complete successful in animal studies, not in human study. And you can see in the different site of nanoparticle injection. Some investigational glaucoma medications like cannabidiol sensitized trabecular meshwork can increase the perfusion, and palmitoyl ethanamide cannabinoid inhaler, but in no role of actually drops here. It is a investigational glaucoma medication. Adenosine receptor agonist, the adenosine increase the conventional outflow facility by shrinkage of cell volume and remodeling of the extracellular matrix in the human trabecular meshwork cell. It is already been established. Posterior receptor agonist omdenopeg, or OMDI, is a non-prostaglandin selective prostanoid EP2 receptor agonist known to decrease intraocular pressure by increase the conventional and UV scale both outflow. Gene therapy, CRISPR Cas9 RNA. Gene therapy can target the genomic changes in the, some trigger gene or mycilin gene. If we can target with those gene therapy, then can prevent even glaucoma progression. Stem cell therapy, already discussed. Thank you so much. Thank you for the patient hearing.
Thank you very much, sir. In the interest of time, we'll take one comment from Dr. Deventuli, sir. Sir, please, your expert comments.
Nikita, I think because it was very similar to the previous talk and Dr. Satyan has very nicely summarized, I think we should move on for the next one, if that's okay with everyone.
Ji, sir. So I will now invite our next speaker, Dr. Pushpa Raman ma'am. And the topic for her presentation is Solving Old Frustrations, Ripassodil and the New Era of Glaucoma Therapy. We welcome you, ma'am.
You are muted, ma'am. Dr. Pushpa.
Hi, sorry about that. Hi, everyone. It's so good to see you all. So good to see all the familiar faces. I'm Pushpa from Malaysia. Before we dive in straight, so I just want to talk. Recently, I ordered a coffee, and then they said they have this new rose latte, and then the picture showing this rose latte. So, and then it looked familiar enough to be a coffee, but it had something unexpected, a different aroma, a different experience, and suddenly something routine felt refreshing again. And that goes to similar to glaucoma. I thought about glaucoma. We often operate with very familiar algorithm because by nature, glaucoma is a chronic monotonous disease. But every now and then, an innovative product comes along and makes us pause and think whether we can manage patient differently. So that's what I'm going to talk to you about. I know the previous speakers covered about Ripacidil, but I just think that Ripacidil is like my newfound obsession, and is I see it changes the way I see patient nowadays. So I want to share my own experience and share with the panel how Ripacidil can change your familiar algorithm as well. There is no actual financial disclosure, but I am a speaker for DKSH and COA, but I don't receive any honorarium for current talk. So as we know, yeah, glaucoma is either we go by all the channels, either you reduce the aqueous production or you increase the outflow pathway. But as we pointed out earlier, there is a great vacuum in glaucoma drugs. But of course, in between, we have a lot of glaucoma surgeries and MIGS and so many things happening. If you see from 1996 until 2001, nothing happened. And thank God Bimatapros came. And then we had this Ripacidil and Netacidil. Ripacidil came around 2014. Netacidil came around 2017. And I think it's about, they are game changer because all the while, the current IOP lowering drugs, we were of course looking at aqueous humor production. And of course, we try to reduce the aqueous, and then we try to see where else the water can flow, the aqueous can flow, if there's scleral outflow and things like that. And actually, we totally forgot about the conventional pathway, the trabecular meshwork itself. And I was so excited when this drug's been introduced because this rho kinase inhibitor, they act right on the point, like they improve the conventional pathway. So if you can see, like back to basics, why there is an IOP increase? Why are the conventional pathway anyway? Because especially primary open angle closure glaucoma and some glaucomas like steroid or inflammatory, even in case like pseudoexfoliation glaucoma, they actually works on the conventional outflow. So rather than seeing how to bypass this conventional outflow, by doing the UV scleral and all those things, we have to see how to actually improve the conventional outflow. So as we know, extracellular matrix in the trabecular meshwork increases in the glaucoma patients. So if you can see the vacuoles actually shrinking, the ECM extracellular matrix is actually laid on more in the glaucoma patients. And there is a narrowing of intracellular spaces, mainly due to ECM accumulation. And of course, due to high IOP itself, the TM cells get compressed, and there is a narrowing of inter-TM cells. So that's how we have increasing resistance in aqueous humor outflow. So there is a closure of collector channels, there is a narrowing of Schlemm's canal, and eventually it leads to increase in trabecular meshwork. So again, that's what we've been doing now. Like, all these MIGS, they came about because we don't know what to do about this conventional pathway, because this conventional pathway, all the narrowing and all those things. So we tried MIGS, we tried SLT, we tried to see how to make this conventional pathway more porous to allow more water to flow. And this is where exactly rho kinase came in. Rho kinase, of course, some basic biochemistry things I don't want to go through about it, but it's the actin cytoskeleton origin, and it modified the cell adhesion and motility. Practically whatever that we want to happen in trabecular meshwork, they make it happen. So eventually, rho kinase inhibitor, it causes a morphological change in the trabecular meshwork. It dilates the lumen in the Schlemm's canal. And also the interesting part is this is the first drug that actually works on episcleral venous. So it causes the episcleral vein to dilate, and then they decrease the episcleral venous pressure. So if you can see here, the rho kinase inhibitor, they act on the stress fiber in the trabecular meshwork and then causes the cell morphological changes. So what we can see by when you start Rho kinase is the early effects are same. As I mentioned, it increases the giant vacuoles, and there is an effect on the endothelial cell. I think our corneal colleagues can comment more on that. And then they change the cytoskeleton contraction. There is an effect on the cell gap. But in later stage, it actually reverses the resistance because it inhibits the extracellular matrix layout, and then it changes the cell ECM relationship. So eventually reduce the resistance of the conventional outflow and give us the IOP lowering effect. So if you can see, compared to placebo and ripacidil, there is a great reduction in the IOP throughout the 24 hours. So here we're able to actually identify the nocturnal effect as well. And of course, there is a conjunctival hyperemia associated with this because that's how the drug works. It's vasodilate. So if you can see the real world study, there is a quite good reduction in the IOP from baseline. And what excites me the most is actually it can help us with the normal tension glaucoma and most of the secondary glaucoma as well. So here I want to point out, whatever the glaucoma that works on the conventional pathway, especially exfoliation glaucoma, pigmentary glaucoma, uveitis glaucoma, steroid-induced glaucoma, I think ripacidil or netacidil, they stand a good chance because they work on the same pathway as well. They kind of like a counterintuitive effect on this glaucoma subtypes. So the study shows amazing results. As I mentioned earlier, so as we compare to other available medication, Rho kinase inhibitor can actually reduce IOP from 15 to 36%, and then it's a BD dosing. But it's just that it's not approved as a first line. So most of the time, when you combine with the uveal scleral pathway PG and Rho kinase, they can actually result in 30 to 40% IOP reduction in normal cases. I think the only place that it doesn't work is neovascular glaucoma. Because as we know, neovascular glaucoma, the conventional pathway itself is gone. Like, there is a membrane, there is things going on. So there is no point adding a ripacidil or netacidil on a neovascular glaucoma. So recently, I was excited enough to be part of the launching of a new fixed combination of ripacidil and brimonidine in Malaysia. So the fantastic part about this ripacidil brimonidine fixed dose combination is they work on all the three pathways: conventional pathway, UV scleral pathway, and then they also reduce aqueous production. So there are multiple studies done, and then I think everyone is quite excited about how this ripacidil antagonized effect of the inflammation in steroid-induced glaucoma. So I'm just sharing a quick note on a steroid-induced glaucoma as a 32-year-old female that presented with me with the intermittent episodes of anterior uveitis. And as you can see, there is a early changes in the glaucomatous changes in the disc because of the high intraocular pressures fluctuations. Her peak IOP is 35, so it's mostly steroid-induced glaucoma. So we put her on multiple combination drops and then actually planned for a glaucoma drainage device, but patient was not keen. When actually I added on ripacidil, it worked wonders. IOP reduced to 15 to 16, and then I changed to Lotimax, and when I off the steroid and reduced the potency of the steroid, the IOP actually further reduced to 12. And currently, we can actually maintain her on 12 to 15, sparing her on the glaucoma surgery yet because she's still young, 30. Of course, if necessary, we will do, but I'm happy that there is something that I can do in between to buy some time before the surgery. And I think that's the most important thing. Yeah.
Ma'am, I'm sorry, but in the interest of time, if you could please conclude. We have another
sure.
speaker also.
Okay, so
Thank you.
the other one is, of course, in the progressive NTG, where I used the combination drop. And then I tested it with the water drinking test as well. So these combination drops, they actually reduce the fluctuations in the long run. So where do you fit in ROX inhibitor is somewhere in between PG beta blocker. And then I would go for ROC inhibitor before the alpha adrenergic and CAI because they do have a lot of IOP reduction effects in the real life. Thank you so much for the opportunity. Thank you for overrunning. Sorry for overrunning.
No, thank you so very much. I loved your coffee slide in the beginning. So I would now like to invite Dr. Manoj Mathur sir for a quick comment as we move to the next speaker after that. Thank you.
Yeah. Like Pushpa, I was also excited with the launch of ROC inhibitors initially, but in the Indian subset of the patients, some of the patients developed gross hyperemia, even leading to corneal verticillata. But what we observed subsequently is the combination with timolol, if it is not contraindicated. Ripasudil plus timolol combination really stabilized the molecule, and the patients started tolerating that quite well. So in 5 drops a day, a combination of ripasudil and timolol with a combination of, say, brimonidine and brinzolamide and a latanoprost or a PG analog use in 5 drops, you can afford a maximum medication, especially for cases where the trabeculectomy, you need to wait for a little time. So in such cases where the surgery has to be postponed, this is a possible combination. So good developments about the glaucoma medications in our armamentarium. We can use it. Apart from glaucoma IOP lowering effect, as you said, the corneal endothelial integrity as well as reduction in macular edema was observed in some cases. So it is of interest to retinologists as well as corneal specialists too.
Thank you, sir. Now we move on to the next presenter, Dr. Andy Ma'am, and she will be presenting on the topic Guardians of the Vision, Indonesia's Evolving Approach to Glaucoma. We welcome you, ma'am. Please share your screen. Thank you. Dr. Andy Ma'am? Ma'am is there? Yes, thank you.
Good afternoon. Thank you very much for the AOS for the invitation. Today, I will share, the topic is quite different with the others. Today, I will present about preserving vision. This is the Indonesian journey of glaucoma care. So as an introduction, glaucoma is the second leading cause of blindness in Indonesia, affecting about 4 until 5 out of 1,000 people, 6 million affected individuals with approximately 1 million suffering from bilateral blindness. And many patients come to us with the advanced stages, and POAG and PACG are still the major types. So this is the 6th pillar of Indonesian Health Transform by the Minister of Health of Indonesia that adopted by WHO. So we do 6 things that are running now. The first is primary healthcare transformation, referral health services transformation, health resilience system transformation, health financing transformation, health human resources transformation, and health technology transformation. So there's some challenge that we have in Indonesia. The first is primary care of physical training. So we done the things and these things, and then we also do glaucoma screening initiative and also technological advancement in diagnosis. So big challenges in Indonesia: community screening program in primary health care. We do identify high risk patient, and then if we have identified patient, we refer suspect to the ophthalmologist. So it will improving quality of the referral. And then in primary care, they do IOP check, ACDIP, and ophthalmoscope examination. And because in Indonesia, we have about 16,000 of islands, so we do telementoring echo for GP and nurses to reach rural area, and they will find cases and then base learning. So this is a screening program for ethnic Indonesian population. So we do public-private partnership, and then if we do diabetic retinopathy co-screening with glaucoma screening, and then we focus on geriatric population in primary eye care. So this is the glaucoma in Indonesia, that data, that 1 year data of a new secondary glaucoma patient of top referral high hospital in Indonesia, and they found that the second is because of the patient come late to do the cataract surgery. And then medical management that available in Indonesia is prostaglandin analog, and then beta blocker, carbonic anhydrase, alpha agonist, and fixed combination. So for the newest glaucoma drops that we have now available in Indonesia is Omni. But in Rokenasa, we still don't have. For the surgical trends, MIGS and SLT, so we do bend up internodontal goniotomy with microhook, and also GATT combined with phaco procedure related to cataract development. And then trabeculectomy still remains standard for the surgery. And then for GGD implant for refractory glaucoma, also MPCPC and also TSCPC. So we also have a international collaboration program. And then for the innovation, so in 2019, Indonesia launched its own locally developed glaucoma implant that we call Virna VGI. So invented by Dr. Virna and Rohto company. So the VGI lowering the cost about 75%, and then the VGI is non-infrared PMMI, and then the placement between the muscle rectus. So this invention won the World Intellectual Property Organization in 2018. So this is the experimental study, and then the subject about 252 subjects. So for future direction, LSS fund the screening, portable tonometry in PHC, and then national blindness prevention programs, also innovation in MIG procedure. Thank you.
Thank you, ma'am. I would now like to invite Dr. Brian Angser for his comments.
Thanks very much, Dr. Devi. I think that was an excellent summary, and thank you for sharing. To talk about your presentation, but I think what your presentation does for me is it highlights for me the various nuances and differences in glaucoma screening and care across countries. And I personally am humbled to realize how much we can and really should be learning from one another, that can only come about collaborations at really all levels. And I think this platform is just one example of how this can happen. So thank you very much for sharing.
Thank you.
Yeah. It's good to see that all kind of developing countries, everybody faces the same kind of an issue. But I think the way we start treating the glaucoma is going to be completely different from now on, because we are just not going to focus only on medications. The new trend, especially in India, slowly is picking up is the SLT for the POAG, though we have the studies been there for quite some time, though we don't really use much in Indian context. I do use it, but then the availability of the equipments and instruments also plays a role. But the SLT is kind of emerging in Indian market. Then the next thing is on the emergence of the MIGS, where the not only the glaucoma people are doing, the non-glaucoma people are also. Non-glaucoma people are also kind of started doing. That is one of the main things that it is happening in India. So that is good to see, provided that we really don't damage too much without understanding. But then the trabeculectomy is going to stay, which gives a solid, rock solid result for a pretty long time. So in my personal view, the role of SLT, MIGS, and the trabeculectomy is going to be the key factors in the long term, keeping the progression at a bay. Otherwise, with the rate of the compliance, when we did the study at the end of 10 years, the follow-up rate is only about 10%. When you have such a poor follow-up, then I think it is better we look at a medication, we look at a procedure that can really help to see the people for long enough, because it is such a chronic disease, and especially those with the younger age group, we are almost going to be sure that they are going to go blind if this kind of a follow-up rate is there. So we need to understand that glaucoma needs to be looked at in a much different way than what we just think. Many times we try to say that, okay, use the drug and come back. Do you think they just have to come back? They don't really have to come back, because they don't really feel comfortable with you. You are just ordering somebody to use the drops for your own convenience. But we really don't involve the patients in decision making of what they really like to have. It is our decision that they have to do this or they have to go for something else. But I think it is the way that we need to change ourselves to make sure that we involve our patients in their decision making of who they want to get treated. Yeah.
Thank you, sir. I would now like to invite our program coordinator, Dr. Rolika ma'am, and Dr. Techi, the session coordinator, to ask questions and their comments, please.
No. Nitika, please go ahead. You're doing great. And Teki, you can take over if you have any questions.
I have two questions open for all. First is there any role of ripasidil in patients with glaucoma with diabetic retinopathy? Then the second question is, basically I'm just asking whether anyone practicing like ripasidil use in patients with glaucoma with diabetic retinopathy. Second is, what is the best parameter that will be used to assess any neurofunctional improvement if really we have a medicine or a drug that will that is considered as a neuroprotections?
Dr. Pushpa ma'am, would you like to take that?
I'll take the ripasidil question. As I said, of course, we are excited about the endothelial cell effects of the ripasidil, the rho kinase and all. But so far, we don't really have any strong clinical studies to actually recommend. And we don't have a real world data as well, even from our retina colleagues. So, I mean, of course, there is no harm. As I put it out, ripasidil really helped with the outflow and conventional pathway, but I don't think there is a clear evidence to say it helps with the diabetic retinopathy.
Dr. Pushpa, if I just put you this question, would you really give ripasidil in many of your patients still, knowingly this has so much of hyperemia? Because all of us kind of almost stopped giving ripasidil unless otherwise there is no other option.
The conjunctival hyperemia, unfortunately, in Malaysian eyes, it actually only lasts for 30 minutes. So we do, and it's only us that how they put it. Worst come to us is 1 hour. So I actually asked them to go the BD dosing. So they put the ripasidil first thing in the morning. When they shower, go to work, the eye is white, and then the last dose is before the bed, so that no one actually.
Such a blessing that Malaysian eyes has.
Yeah, but I agree, because the Indians are the one that the worst off. The Malays and the Chinese patient, they seems to do better. But of course, because of the vasodilation effects and all, yeah, my Indian patients, they suffer a little bit.
Oh, that's great.
Thanks.
Thank you, ma'am. For the second question, any comments from the esteemed panelists and the other faculty speakers, please, on the
There is no
neuroprotective?
established research demonstrating neuroprotection, especially in Brimonidine, in the rat crush model that is always cited. It used 2% Brimonidine as an intraperitoneal injection. So whereas the Brimonidine that we use in eye drops is just 0.0 or 0.1. So the neuroprotection effects are really yet to be established, and I don't see any rationale of expecting too much. But as a like in situations where you expect some sort of neuroprotection or a vasoperfusion, these drugs may have some role. But any parameter to quantify neuroprotection, I don't think we can establish or demonstrate as of now.
It is basically the visual fields as a parameter that they use actually, than any other parameters. Like they're not going to study in like anatomical dissections, but basically when you are using timolol, when the IOP drop is as same as how you see with the brimonidine, and how the visual fields are much more stable with the brimonidine is kind of the way that they were trying to establish that the possible effects of neuroprotection. So it's already been published. To some extent, we can kind of really believe that, but we really don't have anything been published from our side. So I think there is a reasonable belief that there's a possible effect on this.
Thank you, sir. Brian Ang, sir, would you like to add something?
Just one each comment. So I think to the question about hyperemia, maybe Singaporean eyes are quite similar to Malaysian eyes as well. So I do get hyperemia, but like Dr. Pushpa, I recommend the same to patients. I think managing expectations is important as well, and you tell the patient to expect it. However, I would agree that it's not necessarily my first line drug. They would still remain prostaglandin analog for most part as per consensus guidelines.
To both of you, to both of you, Dr. Brian and Dr. Pushpa, do you really see a kind of any surgical outcome change after you have used the Ripasudil? Is that you expect more failures, or have you been seeing that?
Actually, it's the other way because when I went to Japan, I realized that they use Ripasudil prior to MIGS because it's open up the conventional pathway, and when you actually do a goniotomy or a stent, you allow the fluid to flow better. So actually, I'm doing current study. What is the effect of using a Ripasudil prior to the MIGS, and actually quite convincing with that. But the trabeculotomy part is the same. we stop all the medication 1 week before, put them on bread and put in outdoor Dimox and all. So, but I think the rokinase has a role prior to MIGS. Brian, did you try anything like that? Like trying Ripasudil before the MIGS and all?
Yeah, actually, my question was about ROCK inhibitors after MIGS. I think there have been a couple of studies about that. Actually, it kind of makes sense because the angle-based MIGS tackles the proximal resistance, and then now finally we have a drug that tackles the distal pathway.
And it acts on the episcleral venous pressure as well, so it opens up all the way until the distal pathway. I think the Japanese are coming with quite good studies on that. We have to wait for the results.
Okay, thank you all.
Yes, Nitika, go ahead.
Yes, sir. In the interest of time, I'm sorry. And the next session is also there. So I would like to ask from the esteemed faculty if there's any other quick comment, or else I would like to then close with the closing remarks and vote of thanks. So any other comments from the other esteemed panel speakers, please?
I think you can go ahead with your final comments.
So I thank each and every one of you, the esteemed faculty, chairpersons, panelists, and the speakers. Special thanks to Dr. Rolika ma'am, program director, my session coordinator, Dr. Techi, without whom this was not possible. And I am extremely grateful to each one of you. I now hand over the session to the next session coordinators. And the topic for that is MIGS, the current status. So before we leave, a quick photograph, please. So because they start at 7:30, we still have 2-3 minutes for a quick photograph for memory's sake. Rolika ma'am,
Thank you so
over
much.
to you.
Nitika, you can go ahead and take the screenshot. But thank you so much, everyone, for a wonderful session. I think it ran very smoothly and we ended it perfectly on time. Courtesy, everyone. Thanks to all the international speakers as well who took their time out. Thank you so much.
Thank you all.
Nitika, you can go ahead with the.
Thank you all. Dr. Techi, could you please do the honors? So I request everyone to please put on their videos and Dr. Techi will take the screenshot. So once you're done, let us know. We are waiting with a smile. Plaster.
Done?
Done?
Yes.
So thank you to each and every one. And I now hand over the session to the next speakers and the program director. Thank you very
all.
much.
See you. Bye-bye.
Thank you, sir.
Thank you so much. Bye-bye.
Thank you all. Thank you.
Hello, Dr. Shamira.
Hi there. Can you hear me?
Hi.
Hear me and see me?
Yes, sure. Can hear you. Hi, Sunita. Hi, Peter.
Hi.
Hi, Saiban. Hi, Manish.
Saiban.
So, Rolika, they have the option to share their slides and just check it. Hi, David.
Hi.
Yes, ma'am, we do.
Ma'am, we are live, so we can continue, please.
Yeah. Ma'am, we are going to be live continuously, so they can share the screen and check, and we start sharp at 7:30.
Okay. All right.
Right, ma'am.
So the speakers can just check the slides once.
Okay, should I do it first?
Yeah, please.
All right, let me try. Interesting. Okay. All right, do we see it with a monkey?
Yes. Yes, we do.
Okay, good. Then I can stop share. Well, let me go to slideshow just to make sure it plays. All right, you see the actual slide?
Yes.
Okay, and do you see my cursor moving or no?
Yes, we do.
Yeah, do.
Okay, perfect.
Good.
Let me unshare.
Who's next in the lineup?
You can go ahead, Dr. Pereira.
Okay, thanks a lot. Let's see. Okay. So I just want to check you've got this on the presenter view. Okay. Can you see everything?
Yes.
Yes, nice. Yeah.
But none of the text in the.
It's in a presenters mode. Can you just make it in a slideshow mode from top?
Oh, I wanted it in presenter mode. Sorry, but not to show it. How do I do that?
On top, you can change the from top.
How do I do that?
Yes, that's good for us. Is it
Perfect.
okay for you?
Oh, not so good for me, but it will do.
Okay. All right.
Okay. I'll stop sharing then.
Yeah, thanks. Who has Devin? No, Devendra doesn't. Vaishak has one, isn't it? Vaishak, would you like to share yours? Dr. Tariq has yet to join. And Dr. Jonathan has yet to join. Yeah. Vaishak, can
Yeah, I
you?
texted him. Let me call him.
Okay. Vaishak, can you hear us?
Yes, ma'am. Hello.
Yeah. Can
you hear
you
me?
want to share your slides just for a bit?
Yes, ma'am. Just
Okay.
1 minute, ma'am.
Yeah, yeah, sure. We're waiting for Dr. Tariq to come in.
That's that corner one free. That corner one free.
Hello.
You'd like to put it on slideshow, Vaishak?
Yes, ma'am. Is it visible?
Yes, yes. Done. All right. Yeah, that's fine. So it's moving. Yeah, you can unshare, I think. Now we're still waiting for Dr. Tariq, I think. Yeah.
I think he's not able to get the link actually, the faculty link.
Oh,
So I posted in the WhatsApp group.
What happened?
I posted there. Probably he is not having the faculty link. So if you don't have faculty link, he can't join. So I posted in the MIGS group, just inform him.
Okay. This is Dr. Tariq.
I will send him an email as well.
I just forwarded the email to him just now.
Okay.
Good evening, ma'am.
Good evening,
Hi,
ma'am.
hi, Shaban.
Hi.
Long time no see.
I know. And I can still not see you. I can only see your
1 minute,
I
give me a
let you
minute.
know.
Yeah, yeah. Here I am.
Nice.
Hi,
So good to
everyone.
see you. Lovely.
The problem with the mails now, Sushmita, in a day there will be 100 from the AOSC.
I
You have
know.
to really look at it.
I know.
And it's
Imagine.
real.
Even I couldn't find the mail actually. I just asked Sushmita. There are so many mails.
Yeah, I think they bombard you with the mails. How is heat in different parts of the world, rather?
Apparently, Europe is quite hot. So
Yeah,
that's funny.
I can testify to that. I'm on holiday in Tuscany right now, so.
Oh, okay. It's this time the weather is very weird and it's very oppressive.
We had a very pleasant May initially, and now it's come back with a vengeance.
I
For the
have
latest news,
I have a theory. All the burning oil wells are contributing to the
Yeah,
greenhouse effect.
Would be,
and it's becoming super El Nino.
Can somebody mail to Dr.
I did forward to the mail what he has sent.
But I think
I
Tarek
got a
is not-
message from Jonathan Tijerina saying that he's in the room, but somebody needs to let him in. I don't know if is there a waiting room function?
Sunil, can you help with that?
Yes, ma'am. Hello.
Okay.
Yeah, so Dr. Tijerina says he's in the he's in the room but not logged in the speaker.
Dr. Tariq is there.
I'm here, guys. How are you? Lovely seeing you all. Sorry about
Tarek,
the suspense in the last second.
Hello.
Thank you, Vijaya.
I won't blame you. You get so many mails. So I'm sure it is difficult for me to locate it.
And I do many things at the last second, so I'm guilty as charged.
Yeah.
Just
we're
for
starting-
safety, can we send another email to Jonathan, to Harina?
Do you want me to send the link in the WhatsApp group? Will he get it then?
Send it as email.
Okay.
Yeah, if that's possible. Thank you. He's pretty tech savvy, so if he couldn't get in, something must be happening.
But he's already, what did Sunil say? I mean, he's already in the group. Can you let him in if he's...
Send it as email.
I think I made it, Dr. Chang.
Yeah,
Can
He's
you guys-
here. He's here.
He's here, yeah.
JT, good.
Yeah.
All right.
He's pretty tech
Dr.
savvy, so
Kaushik?
if he couldn't get in, something must be happening.
Sushmita ma'am?
Yeah.
Yeah, we're already live. So if you would like to proceed, we can
He's
proceed with
ready.
the
What did
session.
Sunil say? I mean, he's already in the group. Can you let him in if he's...
Send it as email.
I think I made it, Dr. Chang. Can you
He's
guys-
here. He's here.
He's here, yeah.
JT, good.
Yeah.
All right.
He's pretty tech savvy, so if he couldn't get in, something must be happening.
Sushmita ma'am?
Yeah.
We're already live. So if you would like to proceed.
I think the last few seconds are playing up again. If that is right. Good evening, everybody, and welcome to this evening session on the most exciting development where glaucoma surgeons are concerned. And we who've gone through the gamut of only the trabs and tubes era, and for us it's more exciting, but I'm sure the youngsters are getting more exposure than we did. So I'm happy to hand over the session for opening remarks to Dr. Vijaya and Dr. Tariq, who would open it, and then we'll go through with it. We have a very exciting 4 lectures, and 2 residents are going to present their cases from the PGI and the Bascom Palmer. So I'm sure it's going to be a great session. Over to you, ma'am, and Dr. Tariq.
Tariq, you're the guest. You want
Oh,
to
thank you very much. Well, I mean, usually ladies are better and first, but let me just say that I'm extremely proud to be part of this illustrious group of fantastic glaucoma surgeons. Every time I attend anything physically in India or virtually over the internet, I'm always learning a lot from my Indian colleagues. And always the topics of your meetings are incredibly pertinent and to the point. So our session today is MIGS, the current status, trying all of us together to make some sense of what does that mean to our practice and what does that mean to our practice in different places around the world. So I hand it over to ma'am, and thank you very, very much for having me with you.
Yeah, thank you, Tariq. I think without wasting too much of time, and we are looking forward for the different views from across the world. I'm sure this will contribute to our better understanding of application of MIGS in our country. Thank you, Sushmita, for putting the program together. Thank you very much.
Thank you. And with that, it's a pleasure to invite Dr. Shamira Pereira. He's well known in the circle of glaucoma and also in the smaller circle of MIGS from Singapore. And I invite him to give his opening talk.
Thank you. Thank you very much for the kind introduction. I'll just go and get my slides up. Okay. Here we go. Okay, can you see my slides?
Yes.
Okay, thank you very much. So I'll be speaking on the topic of health economics and disparities with MIGS and the developing world. This is actually a talk I gave quite recently in India, and I brought it up to date with a few more pieces of facts as well. These are my financial disclosures. So India currently is a rapidly developing country, and it is bounding towards its developed status, especially over the last 10 years. And if you look at it in the situation with India at the moment, there is several problems which are inhibiting this growth. Firstly, there's the low rate of insurance, the expensive MIGS devices, and the poor access to MIGS, especially rural communities. And the rollout of device, even in India, has been very, very slow. Some states are very few in terms of local government subsidies, and also training opportunities are very rare. Not only is that, but there's a discrepancy in the region as well. As you can imagine, the amounts that local government give in terms of Chennai and the southern Indian region of Tamil Nadu is very different to Bihar and Patna. When we look at the global middle class wave, you can look at that blue wedge there from India, and you can see that this is rapidly expanding, and it will overtake all of the other wedges into the middle class group. Now, the middle class in India, in this group, is divided as households with an annual income of between 6 and 18 lakhs. And I've heard that this is about the salary of a cook in a restaurant. Now, when you look at how India is proposed to grow in that particular group, which includes salaries between 1,000 to 12,000 per year, in India, that middle income group is more closely defined by an annual income between 7.5 lakhs and 15 lakhs. But look at how it's going to grow over the next 10 years. It will surpass that of China. Now, although China's income distribution looks much, much better at the moment, that will quite likely change, especially in the next 15 years. And in the next billion entrants into the middle classes, 88% of them will be from Asia. That means 350 million from China and 380 million from India. So we have it's a very difficult time point for glaucoma at the moment. Whilst we do have the tools and the diagnostics to beat this incredibly blinding disease, especially in low middle income countries, the blindness is still the biggest cause of irreversible blindness in the world because of this glaucoma disease. And only 5% receive timely intervention, and the cost is the main primary barrier. So for MIGS, there are several other barriers as well, not just the cost, but it's the availability, the infrastructure and training, and the accessibility over eye drops. What really matters is the economics, and glaucoma is not just a chronic, costly disease, but it also requires a lot of health economics to support it. In lower and middle income countries, this means out-of-pocket spending predominates, and this can lead to catastrophic outcomes on patients' lives because they can't afford it. Now, I'm going to go through a few details of health economics here, and I'm trying to break it down into simple terms. So I want to introduce this concept of the ICUR, the incremental cost utility ratio, and that's the incremental cost per QALY gained. Now, you have highly cost-effective interventions which have a cost which is less than the per capita GDP. And the cost-effective ones are there when the cost is between 1 to 3 times per capita GDP, and they're not cost-effective when the cost is over 3 times per capita GDP. And then there's this thing called willingness to pay, and that's the consumption value of health. Now, when you look at areas around the world, this per capita GDP is very different. USA is 85,000, Singapore 90,000, India only 2,696. In Africa, it's less than 2,000. So what may work in Singapore will not work in Bangalore. China has another problem with its difference in the rural and urban populations. So what may work in a urban population may not work in a rural population. And when you look at these costs at 5 years and 10 years, these ICURs, you can see actually between the different treatments of TRAB, AGV, ABIC, and GAT, they don't vary that much. And that's because one paper from Paul Healy et al. Showed us that actually it's due to the fact that a lot of the costs are actually brought up by the transport costs and also the clinic costs, let alone the actual intervention itself. So let's do some back of the envelope calculations. For India, the ICUR for the eye stent is about 400,000 per QALY at 5 years and 300,000 per QALY at 10 years. The willingness to pay is less than half of that. And remember that the prospective annual health spend in India was only 6,600 rupees. That's $80 per year in 2022. Remember, for generic medications, that's even 6,000 per annum as well. So what does it tell us? That for now, MIGS is not cost effective for low middle income countries. But what can change that equation? Well, firstly, costs can decrease or complications can decrease, and there may be a need for fewer surgical interventions. That means the ICUR decreases. However, if medication becomes more expensive or less effective for that matter, then the ICUR increases. Now, there's a separate section about the innovation, the intersection between innovation and advocacy. This has meant massive changes to people's lives because of things like local innovation like the RD, which costs just $40, being a 1/6 of the cost of the BAVA, which it represents. And we actually do have to thank those people, like the ones from the Aura Lab, who have made these devices and brought them into the realm of the average surgeon and the patients as well. So look out for other innovations coming out through them, from the Arvind system and LVPI of catheters and other devices to help us. So what do we want from our MIGS? Yes, we all want that low risk profile, the short hospital stay, and the minimal post-operative hospital visits, and the short recovery period, that's for sure. But in reality, the device costs, which are incredibly high compared to trabeculectomy, and the insurance gaps cause some problems. Furthermore, surgeon training has not really been brought through very smoothly in India either. Yet we still want our calorie-free zone. We know that techniques such as GATT, BANG, KDB, the reusable catheters offer some opportunities for device-less MIGS that might be most appropriate in India. Let me take you back to the US situation. Total inflation-adjusted Medicare Part B expenditure rose from 52 to 179 million in 2007 to 2017. That's huge by any stretch of the imagination. And actually, most of the cost was due to the eye stent. The total payment contributed by trabeculectomy and glaucoma devices decreased from 70% to 21%. So the future must be equitable and not just rely on expensive devices. There are these ideas of local innovation, yes, and task shifting will hopefully mean that the general ophthalmologists and not as expensive specialists could be utilizing these devices and using them in the peripheries. There are also policy levers, in other words, that the hospital should also be closely involved with government and the politicians, and they need to change the structure for equitable access. So what's going to be there in the future? We need to advocate for training and local research on MIGS outcomes in low middle income countries. Industry needs to have things like, for example, tiered pricing, where the cost of devices become cheaper the more that we use. And there needs to be a tech transfer to the low middle income manufacturers. So you bring the manufacturing on site in these poorer countries. And we also need to advocate for insurance cover and changes in the governmental systems. So there's a bit more, less of a postcode lottery than you have in the different regions. And we also need to include MIGS in the essential medicines list and universal health coverage. Look at what is happening in today's world with our application of precision medicine. You have a wedding here that costs 600 million US dollars. The groom's mother wore a necklace that was 7.5 million US dollars. Yet less than an hour away is Gandhi's birthplace. Look at the disparity there. So what's happening, and what's happened to be my predictions for the future? Well, I think the GATT is going to really come and really burst onto the scene. It's being used now more and more. And I can see that there's probably going to be a shift rather from the slicing procedures like the KDB and the micro hook to things like GATT. Of course, you have BANG, which is very, very cheap and effective, but they do cause a damage to the trabecular meshwork back wall. And I think this is what GATT will probably give you improvement on. You get a bigger bang for your buck in terms of IP lowering with the GATT procedure. And especially when it's performed with cataract surgery, it's also very low cost with favorable results, despite the inevitable problems of bleeding. So just to go back to Gandhi again, one of his most famous sayings was, recall the face of the poorest and weakest man you have seen. Ask yourself if this step you contemplate is going to be of any use to him. So thank you for your attention and hopeful action. Thank you very much.
Thank you, Dr. Shamira. That was, this gives us a lot of food for thought. And many of us here would say, yeah, we understand that MIGS without a device would be a boon. And we have Devendra here, who is the greatest proponent of that now. I think we'll just take questions at the end. We'll have the first 3 talks because all of them are sort of interrelated, and then we can have a good discussion at the end of them. So I now call upon, I call upon my good friend Peter. You'll go next to GATT or not to GATT, since Dr. Shamira talked about it. And then we'll, of course, go on to MIGS in the era of TRABs, or rather TRABs in the era of MIGS. So Dr. Peter is from Bascom Palmer, and my personal friend, and I have a lot to thank him for allowing me to go into the GATT world, and I dare say stick my head in as well. Thank you for coming on, Peter.
Thank you for that kind introduction and for the kind invitation. And with no planning whatsoever, I thought Dr. Pereira's talk was a wonderful segue into my talk, to get or not to get. That is the question. And I used the monkey photo, which is, of course, dressed up as Hamlet, who asked to be or not to be, because my own mentor, Dr. Hodab, once mentioned that we can teach a monkey how to operate. The key is teaching them when not to operate, hence this picture. And I have the financial disclosure in that I am the royalty holder for the textbook Clinical Decisions in Glaucoma, but that's not relevant to this presentation. So GAT, or gonioscopy-assisted transluminal trabeculotomy, was first introduced in 2014, so a good 12 years ago, by actually a personal friend, Davinder Grover, in the Texas group. And it is basically a modified goniotomy that shares advantage with goniotomy in that it incises the angle and spares the conjunctiva, but it also allows circumferential treatment of the angle. And there are some disadvantages of GAT compared to other types of glaucoma surgery. One is that you need to have adequate visualization of the angle. And there's always a risk of injury to the cornea, iris, and the lens, because there's quite a bit of acrobatics that we're performing inside the anterior chamber. And at least for me, this was somewhat of a difficult technique to acquire. Now, in my personal vocabulary, GAT really is an umbrella term. Okay? It means the circumferential opening of the trabecular meshwork using some type of a filament assisted device. And this filament could be the illuminated microcatheter, which was the original description of GAT. It could be a blunted polypropylene suture, or it could be one of the newer one-hand filament device. So all three of these in my vocabulary equated as GAT. Now, in general, GAT is technically doable if the patient has an open angle and that you can see the angle. And in fact, for children, GAT is considered the first-line surgery when you have a patient with early onset or juvenile onset glaucoma. However, you can doesn't mean you should always. When do we think twice whenever we're going to do GAT? Well, the big question is, will the patient be harmed by common complications? So we need to consider what the common complications are whenever we perform GAT. And the big three that always comes to mind will be hyphema, pressure spike after surgery, and corneal injuries, as alluded to earlier. And we'll dissect these one by one. So hyphema. Depends on which study you look at, the risk of postoperative hyphema after GAT could be as high as almost 70%. And at least some studies suggest that this is relevant to the extent of angle in size, in that if you do a hemi-GAT, the risk of bleeding is perhaps lower compared to a circumferential GAT. However, there's really no other major risk factors. Now, some might argue that if a patient is anticoagulated or if they have a bleeding diathesis, hyphema will be more severe. Yes, we're talking about the degree and the duration of the hyphema, but not the incidence of hyphema. Okay. And why is this bad? Well, as mentioned, if the hyphema persists for a long time, then the eye that we operated on would have decreased vision for a much longer period of time. And this is most pertinent if the patient is monocular and we are operating on the surgical, we're operating on the only seeing eye. On the other hand, if the patient's aphakic, or if they have any type of zonular issues, a pseudophakic or a phakic patient with zonulopathy, there's a risk of the hyphema spilling over into the vitreous and end up being a persistent vitreous hemorrhage. Here I have a video of GAT that I performed using the illuminated microcatheter. And what I want to demonstrate is not actually the technique itself, but rather what happens after you perform the GAT. So here we propagated the catheter all the way around. I'm grabbing the distal end and I'm going to cleave the angle by pulling on the extraocular end. So the trabecular meshwork has been cleaved. Now, if we put the gonial prism back on, you can see these little red dots beginning to form. These are blood that is beginning to reflux into the anterior chamber. And what we can learn from this is where the red dots are actually where the collector channels are, okay? And we are not getting a hyphema because we have somehow inadvertently broken a blood vessel. This is different than the traumatic hyphema per se, but rather a reflux of blood from the episcleral venous system. In this next video, I did a very similar procedure. And you can see that in contrast to the first video, rather than having a very small amount of blood that is slowly forming plumes inside the eye, this one, the bleeding is a lot more exuberant. And what can cause this? Well, many different things. If the patient is awake and somehow they're performing a Valsalva maneuver, or if the patient's head were somehow lower than the body, you can see all that bleeding, much more exuberant compared to the first one. The patients placed on Trendelenburg, for example, you can have a much more exuberant bleeding. So that's where the hyphema comes from. How about IOP spikes? We all had the experience where we perform the perfect GAT and the patient's pressure is good maybe the first day after, but then promptly comes back with elevated intraocular pressure. IOP spike following GAT is defined as pressure that is 10 millimeters of mercury or more compared to their pre-op pressure. And it can occur up to about a third of the patient, and usually occurs quite quickly within the first 10 days or so. And here are two studies I'm going to cite. The first one you see is the one where they show that there's about a third of the patients after GAT can have pressure spikes after surgery. And on the right-hand side is our own in-house study from a few years ago, looking at the risk factor of pressure spikes after GAT. And turns out that if you were to have a child or have a patient who did not receive or use their anti-inflammatory medication, they have a high risk of pressure spike. And if they use steroid as their anti-inflammation medication compared to NSAIDs, they actually have a higher risk also. So no anti-inflammation or using steroid as their anti-inflammatory medication. And why is this bad? Of course, high pressure spikes can cause glaucoma progression. So I want to go over a quick case. This is a young man with a traumatic glaucoma. He's drafted to our university because of his talent in playing baseball, and of course got hit in the eye with a baseball and developed high pressure. So my colleague performed GAT using one of the one-hand device. And here you can see that post-operatively, the pressure remained quite elevated in the 30s with one episode up in the 40s. And this went on for about 3 weeks. And then after that, we ended up performing a fairly emergent glaucoma drainage device implantation. And it's a little bit like a game of choosing your own adventure. Then the patient promptly became hypotenuse and required at least one revision of the glaucoma implant. But the most heartbreaking part is throughout this ordeal, even though his pressure had only been high for about 3 to 4 weeks, his visual field progressed significantly. He went from having a partial superior arcuate defect that completely spares the fixation to having a fixation involving scotoma. And so that's the danger of IOP spikes. Now, lastly, corneal injury. I'm actually going to show you this video first and show you what happened afterwards before we dive into the subject itself. This is a young woman with juvenile open-angle glaucoma, and she had a history of epidemic keratoconjunctivitis. So you see a couple of subepithelial infiltrates on the cornea. And here we're doing the goniotomy, which went well. You can see the landmark, the white back wall of the Schlemm's canal. And we place a catheter into the Schlemm's canal, propagate it very nicely. And we grab the distal end, just like we would all the other cases, and finish the cleavage. And she has a little bit of blood refluxing, and all that's normal and good. And post-op day 1, this is what we see, some hyphema. But what you cannot see very clearly is that there are 2 peculiar lines on the cornea. And when we imaged it, turns out that she actually has large areas of decimate detachment. After further analysis, we realized that when we were doing the GAT using an illuminated microcatheter, we were injecting viscoelastic really quite significantly, and that might have been why the decimate got detached. She recovered normal vision without intervention. But that's one of the reasons why we have to watch out for corneal injury when we're performing GAT. Very lastly, this is a case of a patient who had multiple filtering procedures in the past and were performing angle surgery using the one-hand filament device. You can see there some kind of a cleft seems to have been formed. I thought, no fear, let's go on to the trabecular meshwork and cleave the trabecular meshwork in both directions. You see the bone white back wall, so the procedure itself went well. What I didn't realize, focus on top of the screen, is that this patient had so much mitomycin exposure in the past that the filament actually created a full thickness scleral perforation that took months to heal. He ultimately did well, but that taught me a lot in this case. So in summary, we want to think twice when we perform GAT if there's a high risk of persistent or spillover hyphema, if the patient already has severe glaucoma, because they may not survive the pressure spike, if they have corneal comorbidities, or if there's a presence of thin or abnormal sclera. Thank you very much for your time.
Thank you so much, Peter, for alerting us to when not to do it, and we'll come to the discussion in a bit. I think, Dr. Tarek, if you would come on with your talk on where we stand, where do the trabs and tubes stand in this era of MIGS, and then we'll take the questions. So Dr. Tarek, of course, is the head of the glaucoma service at the University of Geneva. And we're very happy that you've joined us. Thank you.
It's an absolute pleasure. Can you actually see my slides and hear my voice?
Yes, yes.
Very good. So very murky waters of glaucoma surgery. God knows it has always been murky since we started doing glaucoma a few decades ago. But let's try to chart the currently uncharted waters and discuss together where does something like a trab, non-penetrating glaucoma surgery and tube actually lies now in the in the current days where everybody's so excited about new devices and paying extra money for something that might be useful and in many cases is not useful at all. So cost is always an issue all around the world, and this does not mean that when we are considering practicing in India, Egypt, or Switzerland, that the equation is extremely different. Now with the aging populations, everybody wants to reduce the cost of surgery, yet we want to preserve a certain degree of efficiency and our ability to serve our patient and teach our residents. So we now have an ever expanding chart of different devices, different stents, different operations. Good old days when you had trabs and then you had, Barvelt and Ahmed, and deep sclerectomy were just a kind of a new kid on the block, are gone. And although all those new devices come with multiple options for us, but they also come with a lot of challenges of how to figure out what to do and to make sure that you're spending your days trying to learn something new is actually profitable for your patients and results into a positive impact on our patients. We have not reinvented the wheel. We still do operations that do a subconjunctival filtrations, or we open the angle as you have seen with GAT and open the trabecular meshwork, putting something in the suprachoroidal space, or basically turning off the tap and reducing production of aqueous in the form of all sorts of cyclodestructive procedures. And most of all, and actually all of that, we can do ab interno from inside the eye or ab externo from outside of the eye. And ever since the invention and publications of trabeculectomy that started with a flap in a funny place and was changed into a properly placed flap by Peter Watson, the person who actually taught me trabeculectomy. We created, or we received, a gold standard, and everything else we have been really comparing with trabeculectomy. And with all that we have now, it is very pertinent to ask ourselves, is trabeculectomy still of importance, of relevance, and if it is still something that we should work on, teach our residents, and offer to our patients. I mean, of course, TRAB has gone through multiple tweaks and improvements, including the Moorfield's way of doing a trabeculectomy as described by Penn. But the whole idea remains at the end the same. We are drilling a hole in the sclera and partially in the cornea and doing an iridectomy. With that, there are certain challenges, and we have to accept that even when we try to get out of perforating and doing a non-perforating, where we are just removing the inner wall of Schlemm's canal and the juxtacanalicular trabeculum, which makes perfect sense because this is the site of maximal obstruction in both primary and secondary open angle glaucoma, we still had one Achilles heel for both trabeculectomy and deep sclerectomy, and that's the bleb. We all look at our blebs in many cases with awe and pride, when we should be ashamed of ourselves, because blebs are not a good thing. Blebs are basically an insult on the otherwise almost perfect ocular surface of the eyes of our patients. So why not go for something else? And we had the micro shunt actually introduced, something significantly smaller than an Ahmed or a Barveld, which is basically a trabeculectomy in disguise, with the advantage of not creating an iridectomy, but with the disadvantage of having a tube inside the eye. So how did we do with that? Well, you can see in the randomized control trials that trabeculectomy outperformed the microshunt significantly. I mean, remember that many big key opinion leaders in glaucoma always stress the importance of the 1 millimeter of mercury difference. Here we have significantly more than 1 millimeter when we are comparing a microshunt pressor flow to a trabeculectomy, which means that trabeculectomy still is something that is absolutely pertinent for our patients. Now, the other thing is, we now have new devices like the pole implant, like the eye plate, like the ClearPath, which we can always use for more advanced serious cases, especially in reoperations. But all those new devices, even the small humans one that we have been using, come with a price. And the price for the tubes and for the micro shunt pressor flow is that we are significantly and progressively losing endothelial cells. So you are not just paying in rupees or dollars or Swiss francs, you are paying in endothelial cells. Every time you're putting something into the antechamber, be it small or big, be it traversing the sclera into the subconjunctival space, or be it just going into the Schlemm's canal, anything that is protruding inside will result in a loss of endothelial cells, and this is something that is progressive and continuous. Where, if you compare that to a trabeculectomy, yes, there is an endothelial cells loss, but it is a one episode that stabilizes very rapidly. But you put a micro shunt, you put a tube, and as we used to put something like the Express, and every single day the patient wakes up paying for some of his endothelial cells. And that's why, of course, if you put that in a child, and Peter will agree, you can actually calculate how many years before you start putting your first keratoplasty, and how many keratoplasties will the child need if you put something into the eye. With that, actually, we compared the new devices, the Paul implant to Ahmed implant, knowing that both of them are efficacious in a way, but one of them is significantly smaller in diameter into the antechamber. And yeah, I mean, there was no inferiority for the Paul versus the Ahmed, I would say so. But I have to be very honest with you and say that I do not, from the data that I'm seeing now for the 3 years, foresee a significant improvement in terms of endothelial cell loss. So again, we can go smaller and we can go smaller, but the actual presence of a device inside the antechamber has a price. Now, again, we are getting smaller and smaller in devices. Now we have the iPlate XS that has a 0.4 outer diameter compared to a 0.46 with a pole. And now, and it becomes a little bit funny because I do not see, from all that I've seen and known and have done, that a 0.006 millimeter difference between tubes will make such a big deal. So if you're asking me about if TRAB still is pertinent, I'm sorry to tell you that I'm not sure that you can handle the truth. And I can tell you that, yes, of course, we have to continue to practice and teach trabeculectomies, but we have to, with the opportunities that we have today, to actually always teach better TRABs, better deep sclerectomies. And we can always consider tubes in advanced cases, and we have to make sure that we do not overuse any of those new devices, not just because they're expensive, but because in terms of efficacy, as you've seen, the microshunt, which is probably one of the most efficacious new devices, is still significantly less than a trabeculectomy. So with that in mind, I will tell you that in a lifetime of glaucoma surgery, I still believe in TRABs. And I finish with having spared 1 second. Thank you very much.
Thank you, Dr. Tariq. I think we all sort of echo that learning TRABs and tubes is going to stay. Having said that, I think we'll take a couple of questions on the first 3 talks, and after 10 minutes, we'll take on the 2 cases and have discussion there also. I'll start off with Sunita, who's at the Shroff Charity Eye Center, Delhi, and she has a fair amount of experience in the KDB and other trabecular stripping, as well as she's lucky enough to have an experience of devices. So Sunita, does the efficacy matter between a device and between, say, a KDB, oblique tenito, or a GAT? Of course, a GAT I expect to be more, but does the efficacy really matter for you?
Yeah. Can I speak?
Yes, please.
Yeah. So efficacy in a glaucoma patient does matter because we always tend to set the target intraocular pressure depending on the severity of glaucoma. So it depends like what type of glaucoma you're dealing with. And if it is a moderate to advanced glaucoma, then you want to reduce the pressure to maximum to achieve the target intraocular pressure. So I do believe that the devices we generally use in mild to moderate glaucoma as compared to the to GAT, which is much more efficacious as compared to devices. So yeah, I agree
Let me put it the other way around.
Yeah.
If you're saying trabecular stripping is more efficacious,
Yeah.
you really need to implant a device then.
Yes. So, see, again, we have different types of patients. And now the concept of interventional glaucoma. So devices I use mostly when I'm doing cataract surgeries and the patient is on 1 or 2 medication, mild to moderate glaucoma, where I don't want to do a procedure like GAT, which can lead to complications like hyphema, and it is actually not required to strip off 360 degrees of trabecular meshwork. Then devices can perform much better. They're much more safer and with as good an outcome as cataract surgery in terms of complications, like you do not get to see hyphema the next day. So that way I prefer devices in patients with mild to moderate and with cataract surgeries.
And suppose you just did a 100-degree stripping or something, KDB versus
You
a
can,
device.
yes, you can do stripping. Then again, Dr. Shamira talked about the health economics, and then you have to choose patients, the patients who are insured, who can afford devices. Then I may still go for devices, and because devices are much more expensive. So if the patient can afford it, if the patient is insured for that, then definitely I think I would like to prefer more safer technique, which I feel that devices are slightly better in terms of safety because they do not cause hypema and all the next day, and because the patients expect very good vision. But yes, I do a lot of KDBs, and 90 degrees or 120 degrees KDB is equally good. So either of these, but I would not like to do GAT in those patients where the glaucoma is mild to moderate. So the indications may differ.
So Manish, I'll take it to you. Does implanting a device in your patient depend solely on economics? Or is there a patient in which you would say, I would put a device only?
I think in our practice, the approach has been key. See, I think in India, MIGS is still evolving and so many newer things are coming. We are also trying. We have been doing Bang, Visco Bang. We also have the Tanito, even the Devens hook also we have to be using. So I think as a surgeon, I feel we are also evolving and understanding MIGS better and getting our own data, how we are getting the results over time. In our practice, we offer the patient everything, the implants, the KDB, even the bang. GAT, like Dr. Sunita said, we don't offer it for mild to moderate glaucoma. So it's not something which we offer with cataract surgery. Again, more so because maybe we are not that comfortable with GAT. We are more comfortable with the KDB and the implants. And we have to think, since glaucoma patients are with us for a very long time, so we also have to look into the value, cost, and the IOP is to value relationship. Like Dr. Samira was telling very nicely that in price of one eye stent, you can do 5 trabs in India. So we have to look into that aspect. And when we talk about per capita income, where in India is around 20,000, the price of one eye stent is like 7 to 8 months salary of an individual. So thinking that aspect, we do offer implants to patients for MIGS. But when patient asks us what is your preferred, we generally go with KDB. We tell that this is good enough because this gives you a very good IOP reduction. And most studies have shown that KDB is as good as the implants, if not better. So we are not compromising on the efficacy, and we are giving you a same thing at a much reasonable cost. So this has been our approach.
So Shmita, you want to add in terms of efficacy, the drug-free part also?
Yes.
Because that also is a part of
True.
efficacy.
Absolutely.
When you do a glaucoma surgery, you have to look at that.
Yes.
In that context, can Peter comment about long-term outcomes of GAT in adult glaucomas?
Yeah, so wonderful discussion, and it's actually great to hear different viewpoints and have my own assumptions challenged, which is always interesting. Long-term efficacy data for GAT is actually not terribly robust. Okay, and the set of data that I'm most familiar is those with early onset glaucoma. I think the success rate, if you push it out really, really far and you're looking at all-cause glaucoma, 5-year success only about 60%, and this is qualified success, right? So complete success will be even less than that. However, the qualifier being, if you look at just a subset of developmental glaucoma, the ones who you want to have done the best for the longest time without a bleb, without hardware, the primary congenital, and the juvenile open angle, those success rate could actually be quite decent, up to 70 to 80%. I think the study out of Wills Eye Institute, Wills Eye Hospital, and out of Texas show that in adults with primary open-angle glaucoma onset after age 50, so that's sort of the population that we as a group here are talking about, it's only about 50%. Now, I do want to offer one insight about that, though. 50% outcome over 3 to 5 years for a glaucoma procedure does not seem terribly robust. But if you are dealing with an elderly population, many of them might not need anything more just based on their life expectancy. So for some patient, that might be good enough without heading down the road of blood management, blood bleeds, corneal transplant, etc. So that's my 2 cents.
I'll go on to Dr. Devender and ask you the same question that Dr. Peter asked, when not to GAT, because I think he's 100% GATter, if I'm not wrong.
Thank you. So not only GAT, I not only do GAT, I do also do KDB, I do Tanito, I do my own Deodal hook. So the Chang really beautifully put out the things in a very nice way. He picked all the three, he talked about 3 things. First, hyphema, IOP spike, corneal injury. So I say one by one. So hyphema, the most are transient, 50 to 60% resolve within 2 to 3 days. Only hyphema, they require the AC wasp in more than 2 millimeter, and that also you can be just choose the AC wasp and clear it, and you don't have further. So we did one study where we did observe the 1623 patients. Out of them, 20 got the hyphema. They required AC wasp, but the outcome at the 1 year in terms of IP control, use of anti-glaucoma medication, BCBA, everything was similar. So I don't think hyphema is a big deal when we're dealing of any kind of MIGS surgery. Then coming to IP spike, I think this is a transient. You can resolve within a treatment of 5 to 7 days with Diamox anti-glaucoma medication, steroid. Coming to very important point you told about the corneal injury. So really, why we get corneal injury in the GAT? When you use the catheter, so when you use catheter diameter around the 200 micron, while we use the fibroproline suture, the diameter range from company to company is 100 to 125 to 150 micron. So really we do a lot of thousands GAT. Really, we didn't get any kind of corneal injury. We don't get iododialysis. We don't get such kind of complications what you're talking about. And one more thing, Peter, I will want to enlighten you. GAT is not restricted to only POAG. GAT even you can explore in the PACG also after doing the goniosynostolysis. And last comment, if you talk about the efficacy of MIGS, GAT is the only procedure which will give you the 40% of eye reduction. Your 70 to 80% of the patient at the end of 3 years are drug free. I think there's a fair for the GAT to do.
Coming back to you, when would you not do it?
Yeah. So really, I don't venture because my past experience, especially with the neovascular glaucoma and total synovial closure, these are the 2 things I don't venture. Or I have limited success in silicone-induced glaucoma. Otherwise, each and every case before trap and tube, I do the GAT.
Thank you.
Can I ask a question to Peter, Sushmita? Because
sure.
Peter, we have a lot of questions in the mind. When you said that the 3 to 5 years, it's 50%. When they fail, does the IOPs becomes very high because of the damage to the trabecular meshwork? I'm curious. Do you think they respond very poorly to the medication? You may have to end up doing another procedure?
Yeah, so that's a good question. First of all, the study definition of failure in the ones I'm citing does not mean glaucoma became out of control. Okay, it just means that there's a predefined pressure lowering and the eye is no longer at that level. Okay, that's what they meant by failure. Means that the effect of the surgery went away. Doesn't necessarily mean that the eye require another glaucoma surgery. Okay, in fact, I think when of all the eyes that failed in GAD, we're talking about adult with open angle glaucoma, only about a third require more glaucomas. Okay, so that's that cohort. As far as reason for failure, I think that's open for speculation. One thought is that when you have chronic glaucoma, open angle glaucoma, we believe that trabecular meshwork is one of the sites for the increased resistance, but not the only site. The episcleral venous system can also be damaged by chronic inflammation, especially, ironically, from drug-induced chronic inflammation. And just as a spoiler, I'm just about to complete a study looking at the efficacy of whether a patient responded to SLT as a predictor of whether they're going to respond to GAT. Turns out that if they don't respond to SLT, meaning that they might already have a poor distal outflow system, they typically don't respond terribly well to GAT. So I think what this had taught me was to think about GAT in a way where it's not just at the trabecular meshwork, but also we got to think about what's going on in the downstream. And in my opinion, that's why it tends to work so well for juvenile open-angle glaucoma, you know. And Sushmita, you know this too. You have patients coming with 3 degrees of visual field, juvenile open-angle glaucoma, never had one eye drop in their life because they just got diagnosed. And you do a GAT, and 10 years later, they still have a pressure of 10 or nothing. And you just don't see that on patients who have multiple medications, I think because it somehow damages their episcleral venous system.
And another small thought on the episcleral thing, I've noticed that one would like to think that steroid-induced glaucomas is a trabecular damage procedure and a GAT would work well, but sometimes steroid-induced glaucomas continue to have high pressures if we put them on steroids. So it's possible that the outflow also has receptors like the TM for steroids. So I'm very, very scared of putting them on steroids, and I've reduced my steroid drops to them to almost just 2 or 3 days and then put them on NSAIDs after I've read Peter's paper, and it makes a difference. So reducing steroid, because we know that all POAGs and GOAGs are high steroid responders as well. So there's something to the outflow being not good enough, I think.
Yeah, the thought is that the glycosaminose glycans can very easily narrow or occlude the collector channels, just as the effect it has when you have an intact trabecular mesh. So pathophysiologically, it seems to make sense to have steroid response after cleaving open the trabecular meshwork.
Yeah, apart from that, the GAT has very, very good outcome PXF glaucoma. PXF glaucoma, you do the GAT, your success is more than 70 to 75% at the end of 3 years. We have the outstanding results in PXF glaucoma. That's already reported in the literature.
Thank you. I think in the interest of time, we'll move on to the cases now. We have 2 fascinating cases by 2 fellows across the globe. The first one is by Dr. Vaishak. He's just finishing his senior residency. Vaishak, are you around? Oh, yeah, there he is. So he's just finishing his senior residency, and unfortunately, he's ready to fly over to Peter, and I'm not happy about that at all. But anyway, so Vaishak, we'll have your case, and then we'll go on to Jonathan's.
Thank you. Good evening, everyone. Today, I'll be discussing MIGS in advanced secondary glaucoma. Hope here to stay. A 11-year-old girl child who is a known case of JIA-associated uveitis with glaucoma, who underwent both the cataract surgery 5 years ago and is on methotrexate weekly injections. She underwent left eye Ahmed Kleber ligature in April 2023 and had persistent hypotony of IOP of between 2 and 7. But it was maintained at 6/9.
Sorry, Vaishak, is anybody else logged in that room? Because there's a lot of echo. I'm sorry.
I have 2 systems here. I'm just shooting.
Yeah, because there's a lot of echo. I think there are people logged in the same room. If you could just, yeah, okay, carry on. Thanks.
Now is it okay? Yeah. So sorry for that. So her right eye IOP started rising from August 2025, and the agents were added accordingly. So her best contribution activity was 6/9 in both the eyes, with IOP of 44 on 4 agents and half tab acetazolamide, and with coverage ratio of 0.7 to 0.8. And the left eye IOP was 2 off agents with around 0.8 cup the left eye. She had iris Bombay of 60 degree in the right eye. And the gonioscopy showed closed angles in all 4 quadrants. And the ASOCT also showed iris Bombay and closed angles in all 4 quadrants. So what are the options that we have? Can we do just a surgical PI? As she was a child, she was not cooperative for laser peripheraldectomy. And it was a case of secondary angle closure with dysfunctional team. A simple PI may not be enough in that case. and she may need repeat surgery and GA just as the surgical PA doesn't work. So we opted not to do that. The other option was to try a trap, but there's high risk of failure as it has a uveitic glaucoma, and was a high risk of hypertony as she had hypertony in the other eye previously. So we tried to not do that as well. The other option was to try GDD, but she may need repeat surgeries later. So why to use the last bullet first? And there is high risk of hypertony as she had hypertony in the other eye with GDD. So we tried not to do that as well. So our thought process was, can we hazard a mix in this case? Something like CAT will have a low risk of hypertony, maybe enough combining with the surgical PI will preserve the conjunctiva for future surgery, and the pathology is at the level of TN, so removing that might just be enough, but might as well be safe and effective. So our plan was to hazard a try if we see a TN on table. So on table, after doing the synovial lysis, we did a surgical PI, following which the AC got deepened. And after putting visco inside the AC, a good team was visualized and the goniotomy was done. And the Prolin suture was introduced into the Schlemm's canal. And after about 10 to 15 throws, 360-degree Schlemms were cannulated. And the other end is grasped with using mastiff forceps. And the 360-degree gap was completed in the child. Following which replaced corneal sutures were placed. And irrigation and aspiration was done. And the corneal sutures were completed. And the thorough AC wash was done to remove the hyphema. And the air bubble was kept in the case. So on the post-op day 1, her visual acuity was hand motion close to face with IOP of 20 off agents, but she had some loose bloods and air bubble inside the AC on the post-op day 1. After 2 weeks, the hyphema has disappeared with visual acuity of 6/24 and IOP of 14 off agents, and she had very deep AC, and the cat cleft was visible in all the 4 corners. Even after 3 months, her visual acuity is maintained at 6/12 and IOP of 10 off agents, and the AC is adequately deep even after 3 months. So the uveitic secondary angle closure glaucoma is difficult to manage, often requiring multiple surgical interventions, especially if they are presenting in childhood. It will be more difficult to manage. And there is high risk of hypertony with TRAB and GDD. CAT often tackles the pathology with low risk of hypertony and is effective in such cases. Thank you everyone and have a great day.
Thank you, Vaishak. I think we'll go on to the next case, which is also on GAT, and then we'll open it up for discussion till the end. Dr. Jonathan, happy to have you. Go ahead. Dr. Jonathan is also from Bascom Palmer, so we'll hear his case. We were actually debating today evening before going home, what does retroillumination mean? So let's see what it means really.
Hello, everyone. Thank you for having me. I am one of the glaucoma fellows. I work with Dr. Chang very closely, so we'll be sharing. I didn't realize that my case was going to seem so much like an example of when not to do GAT that after Dr. Chang's talk, but we'll talk about what we think about that here. So this is a technique I developed with Dr. Bitrian, one of our other attendings at Bascom Palmer, who is kind of on the opposite end of the spectrum in terms of wanting to always GAT everything. So this is our talk is entitled "The Light on the Other Side of the Tunnel: GAT Using Retroillumination of the Trabecular Silhouette." We have no financial disclosures. Our talk starts with a 36-year-old male patient with a history of developmental delay, strabismic amblyopia in the right eye, and a history of chronic eye rubbing, as well as a history of keratoconus that ended up having 2 PKPs bilaterally 2 years prior to seeing our service. He did develop an episode of acute graft rejection in the left eye 1 year following, which was treated with topical subtenons and oral steroids, which ultimately resulted in him developing a steroid response. His pressure in that eye was 44 at maximum, luckily stabilized in the high teens, low 20s on 3 agents, 3 classes of pressure lowering drops, and a switch to loteprednol. Unfortunately, he did develop bullous keratopathy, recurrent corneal edema, and a PSC cataract eventually, was referred to our service to optimize for potential DSEC under PK, This is the fellow eye with plus minus MIGS if we were able to by doing a phaco. This is the fellow eye. Looking at the operative eye here, you can see an NSEG OCT through this region shows the corneal edema, the bullae formation, as well as a deep AC because his axial length is about 26. Best corrected visual acuity in this eye was 2200 with a pressure of 23 on 3 classes in the pre-op visit. His angle status, we are unable to gonio him very well in clinic, but we're thinking that we have a sufficient view temporally at least to try for a nasal angle-based procedure if we're able to get through the phaco safely. Severity and staging were very difficult because he had difficulty with fixation and wouldn't do a visual field because of the developmental delay. So we feel that probably this eye has better visual potential than the other eye, given that he had the history of strabismic amblyopia on the fellow side. Our ultimate plan was a phaco plus minus GAT. And this is a representative case. This is not the exact same case. Actually, I was adjusting the lighting settings on our case so much that I turned off the microscope camera for that portion. But we use very similar techniques on this corneal opacity case where we're using trypan blue. We're minimum hydrodissection, minimal rotation, using phaco chop techniques and trying to get everything supracapsular if we can. Ultimately, we would rather the endothelium take a hit instead of the posterior capsule. So often these cases, the cornea becomes relatively steamy, and we end up using a light pipe as pictured here to give us a better view. In this case, we ended up putting a 3-piece in the sulcus, but in our case, which is we're returning to here, I was able to get a 1-piece in the bag after using the endoluminator assisted technique for the phaco portion. Unfortunately, this is the view that we were left with after we had finished the phaco. So our options here, we were planning to do a GAT, but our view is looking very foggy. And we decided we were thinking about potentially stopping just with the phaco. That may be sufficient given that his pressure wasn't extremely poorly controlled. We thought about converting to an ab externo approach. We thought about doing a transscleral or an endo CPC even. We thought about converting to a subincisional or subconjunctival incisional based approach, but in this gentleman's case, he did have the history of developmental delay and eye rubbing, so we wanted to avoid those if possible. And we could also just call it good and I leave the country. We decided to get creative, which is Dr. Bitrian's specialty. We did see, we already had the endoluminator light out for the phaco portion, and when I applied it to the sclera opposite the incision, we cleared the heme, we realized we could actually start to see this sort of shadow of the trabecular meshwork here, which we've come to call the trabecular silhouette. And we've used this many times since on cases, especially pediatric cases with corneal striae that makes the view difficult to see. So I go in, I take another attempt at getting this superior hemigat done, but I end up prematurely ripping the trabecular meshwork a little bit. We're seeing that I'm getting some traction, so we decide to go for the inferior hemigat here, and I'm able to cannulate it successfully. You can start to see that trabecular cleft forming right there. And we don't get quite a 180-degree tear, but pretty close. And so we're really happy at this point that we've got the inferior hemigat. We debated calling it good, but we decided that we were going to go for the superior again. So when we zoom in here, you can actually see the cannula goes down or posterior because I had already prematurely ripped the trabecular meshwork there a little bit. But now it's fully cannulated. And again, not quite a 180-degree tear, but we get a really good superior hemigat as well. And you can track the progress with the endoluminator all the way to there. Here we're inspecting our work. We can see that sort of bone white back wall that we always talk about. And the trabecular cleft has formed after we've been able to get that done. So we clean out the viscoelastic, hydrate our wounds, given eye rubbing. We decided to, we suture the wounds to make sure that he doesn't rub and cause any problems with iris prolapse afterwards. This is the technique with lightly pigmented trabecular meshwork, just demonstrating that it can help you see those angle structures that otherwise would be difficult to view. Sometimes we even turn the microscope light off in order to help with the visualization initially. This is how we apply it on the sclera, and his final visual acuity was 20/30. IOP of 8 on just COSOPT, and we've avoided, or dorzolamide and we've avoided repeat PK. So this technique helps with visualization through corneal opacities or poor red reflex in the case of a cataract surgery. You can position the endoluminator outside the AC or inside the AC with a separate incision. For retroillumination of the trabecular silhouette, it helps in this case when you're doing an angle-based procedure with corneal opacities in the way. You can also maximize coaxial lighting and minimize diffuse. And it may be helpful not just for GAT, but any other angle-based procedures. Thank you.
Thank you. So now we know what retroillumination means. Do you do that routinely? Do you need the endoilluminator of the vitrectomy system, or can any illuminator work? Or do you need
Yeah,
more?
we have started doing it. This actually was the case that kind of inspired us to start doing it, and we've done it actually a good amount since then with cases where they have either had corneal transplants or if they just have primary congenital glaucoma with corneal striae. You can use the endoluminator probe either attached to a separate machine or just to the laser. But we have been using the endoluminator probe. One ophthalmologist who I showed this to told me that he sometimes will do this in clinic with the muscle light when he's gonioing, and you can see kind of a similar outline. But intraoperatively, we've only used the light pipe.
Okay. Right. If you could just unshare, so we'll start the discussion. Thank you. So I'll go on to Dr. Shamira. Is Dr. Shamira there?
Yeah, hi.
Yeah, hi. Jonathan, could you please unshare your screen, please? So that everybody
I
comes.
am
Yeah.
trying to unshare.
So in the meanwhile, while he is doing that, can somebody from the back end help, please? To unshare his presentation?
I'll do that, ma'am. One second.
Thank you.
Thank you.
I'll just try that.
Then we can have everybody on screen. So Dr. Shamira, what I was asking was, this seems to have become a GAT session rather than a MIGS session, isn't it? But yeah. So would you think about any MIGS as a secondary procedure once your primary has failed?
No, I don't think so. I think that once you've given it a good shot with the first one, I mean, it has to be a good shot, of course, right? Then you have probably had your best go at it. And I don't think that people are really doing a second MIGS procedure. In any case, in many of the device companies, it's actually contraindicated anyway.
All right. And since you're practicing in Singapore, you would have your share of angle closures as well. What would be your take on MIGS after synechial in angle closure? Because
Yeah, it's quite interesting. So I mean, we produced a study from Singapore, a phaco GSL versus plain phaco study a few years back. Main author was from SNEC, Rahat Hussain, and they actually showed that in that group of patients, the whether we did GSL or not in patients with over 90 degrees of PS, it didn't really make much of a difference. So the theory after that was that we shouldn't do it. But when you look at the sub-analysis of the two groups, we found that actually there was quite a large difference, with those patients who had significant glaucoma and who had chronic angle damage, and those who had, just acute attack basically, or very short subacute attacks and PS formation, they did well. So the ones who did badly were the ones chronic, not surprisingly, and the ones with the acute spikes, did very well. My personal preference of choice is to do as much as you can in the angle with your phaco. So I'm a big proponent of phaco, GSL, and goniotomy. Now remember that it's slightly different in these eyes because the goniosynovitis has led to some bleeding. Sometimes it gets a poorer view. Your best shot is your first shot. And the angle actually physically does seem smaller in these angle closure eyes. The dimensions physically are smaller, and so you might find it difficult to go all the way around. But nevertheless, I will try and go for as much as possible phaco, GSL, and goniotomy.
And the goniotomy would be a KDB, Tenito, or
No, a GAT.
It would be a GAT. Okay.
It would be a GAT. Yeah, do as much as you can whilst you're there.
Yes. We've actually found that in angle closure eyes, they seem to do better than the POAG eyes. And I don't know, but it's possible that the outflow is less affected in PACG eyes than possibly in POAG eyes, but I don't know how to prove that, but that's the only explanation I would have. Dr. Tariq, sorry, yeah, carry on. Sorry, you were saying something?
No, I think if you look at Sulan's work from China, I mean it's very promising, and she has a control study versus trabeculectomy and very similar results. But I think you have to be a bit cautious. She's doing a lot of them. She's very good at it, and people who have not yet seen the complications that can happen, do need to be a bit careful.
Sure. Dr. Tariq, I was asking you, do you see GAT or any MIGS in the advanced glaucoma space, or would you always bat for a trap? Because GAT seems to work even in some advanced glaucomas.
Yeah, I mean, when you have an advanced glaucoma case and it has a virgin conjunctiva and a decent conjunctiva, there are not 1,000 options when it's an advanced case. All of the so-called MIGS are not really the optimum option for advanced cases. So again, you are left with a deep sclerectomy, a trabeculectomy, a tube, or a GAT. Again, primary tubes is something that you have to be very cautious about. If the conjunctiva is really bad, then that is actually something that pushes you more towards a GAT in an advanced case. But there's also the other argument of trying a GAT in advanced cases, leaving the conjunctiva for a trabeculectomy. I do not believe that once you do, or I do believe that once you do a GAT, a deep sclerectomy is no longer an option. So again, it all depends on the knowledge base of the surgeon, what the surgeon is comfortable with, what the surgeon have practiced and have done. I mean, anybody who's very comfortable with a deep sclerectomy or trabeculectomy, then I think they are absolutely a valid option for advanced glaucomas. Now, somebody that is well versed in a GAT, I wouldn't criminalize a GAT for advanced glaucoma cases.
So if I flip the question, and at least for us who are working in institutions, the advanced glaucoma that we get are those who've been on years and years of meds, and finally they can't take it anymore, so they come for a second opinion. So they have really bad. They have even PAPs. They have red conj and a hot eye. So would you tilt your scales a little more for an ab internal thing in that, even with advanced glaucoma?
Sure. I mean, in a case where the conjunctiva is terrible, I would always consider a GAT in these cases. But the trick is to identify bad conjunctivas from good conjunctivas, because sometimes it can be very deceptive. And I always say that to my fellows that you need to use the lid margin and try to mobilize the conjunctiva, see how good it is. You can always put a topical anesthetic and use a cotton bud and try to move the conjunctiva. It's really, really important to acknowledge that the conjunctiva in most of our practice is our, raw material. It's our bread and butter. So before going to the operating theater, not knowing what conjunctiva you're dealing with is shooting yourself in the foot.
Sure. I think we have the last 4 or 5 minutes left. Ma'am, your take on both cases.
It's very interesting, very good discussion. So coming back to Tariq's comment about the knowledge and experience, I think that's a very important point, and ultimately the aim is not to harm the patient.
Yes.
So in that context, because there are a couple of people from Bascom Palmer here, years back when we used to have a glaucoma forum, so one of the comments that Douglas Anderson made at that time with the discussion about a complex case, what works best in your hand is the best for the patient. I think that has to be kept in mind when we are offering as a last resort in advanced glaucomas. So I am a proponent of bringing in the knowledge and the new techniques. We have to keep changing our practices with the time. There is no doubt we have to adopt the new techniques. At the same time, we have to keep it in mind that what you are capable of in offering the treatment, not to yield to the pressure from the others. I think we are going to use different techniques. Each person will have their choices. I think ultimately the safety of the patient is the most important.
Can I mean, I think this is a very fair point that we should not at all neglect. Peer pressure is one of the sources of multiple evils. So if a person can be wise enough to protect himself and shield his patients from taking decisions under peer pressure, I think it goes well for everybody.
Any other last minute comments? We have about a couple of minutes more before we wind up with the
share a quick thought that actually was forming as this forum has started about an hour ago. It was interesting to be talking about GAT, watching the techniques, watching Tarek's videos about traps and tubes, which is focusing on that individual eye that we're dealing with, while having the preamble of Shimura's excellent talk about the health economics of the entire society. And sometimes I find myself at odds in that a patient will come in with a lot of resources. You know, Bascom Palmer, we get a lot of the medical tourism patients who come in and want to try the best and newest. Even I told them that this is not likely to work. They said, I can afford it, let's try it. It's a decision that you make when you're facing the patient, sometimes goes against the odds of what is the best decision for the society as a whole, isn't it? Because you're utilizing resources that the next less resource-rich patient could possibly use. But because this patient is willing to pay for it, you try the GAT, knowing that maybe there's a 10% chance of it working, but he does not mind coming back later for a tube shunt. So you go through the algorithm one by one. But if we were to have a single payer system, you know, the UK, for example, I would believe that some of the procedures where the likelihood of success is deemed to be too low would not even be allowed to be done. And that's making a decision on a societal level such that we as a group will be able to help the highest number of people to stay sighted without going blind, without utilizing extra resources. And I find this conflict very interesting. You know, when are you a good citizen versus when are you the good doctor that a patient wants to hug because you did what they ask? I don't know. This is something that I'll be struggling with at least for the near future.
I mean, if I may say, Peter, you know, with some of the devices that are very expensive and not at all efficacious, you can still be a good clinician to your patient and a good citizen. I mean, they help you with that being not that effective.
Yes, happiness doesn't always come with lowered IOP. Yes, I agree. Yeah.
I will add, Peter, one more thing. You talk about the monocular patient. So when the VFI is 7, 5, or 9, 10, really, I'm very confident to doing the trap, doing the GAT instead of the trap and the tubes. Because really, trap, how good we don't know what's going to happen next day, actually, even being the experienced of thousands surgeries. But you do the GAT, you know maximum what will happen, only hyphema that you can clear off. So really,
that's exactly right. That's exactly right. Yeah.
So I think we have to wind up. Thank you very much. I wish this was a 5-hour session because we would have had lots more fun. But are we ready for a picture with smiles?
Yes.
We can all say GAT or MIGS.
Yes, I'm going to just to honor the distinguished gathering here. We've had a great discussion, and although we are ending the session here, I'm sure the ideas that we've shared will go far beyond this room. Thank you so much. The picture's done.
Thank you.
Thank you all.
So much.
That was very enjoyable. Thank you.